Hi, everyone. Thanks for joining in. We'll be starting with the next session at 4:30 p.m. sharp.
Hi, good evening. Thank you, Diksha. Who will be keeping the timing, Diksha? Will there be anyone
Yes,
prompting
there
the
will be a
speakers?
timer set up. Yeah, there will be a timer
Okay.
set up. Yeah.
And for what time is it? For 8 minutes or 10 minutes? 10 minutes.
For 10 minutes, yes.
Okay, great. Hello, everyone. Welcome. Dr. Geeta will join, so she'll be starting the program.
Sure.
Dr. Geeta.
I see Dr. Geeta has already joined in. Hi, Dr. Geeta. Good evening.
Good evening.
Great to see you.
Yes, great to see you too, Diksha. Good to see all of you.
Hello,
Hi, Pallavi.
Hi, madam.
Hi, Jay. Hi, Swapnil. Hi, Jaya. Sharon is there. So, 4:30 we'll start.
Yes, ma'am.
So, I would like to thank all of you for having, agreed to be part of this session. I think it's turned out very well, shaped out very well. So, it's something interesting to look forward to. Diksha, will you be giving us the cue to start? That will be at 4:30, right?
Yes, sharp at 4:30. So I will quickly introduce this session and then I'll hand it over to you, ma'am.
Sure.
Good to start. A very good evening, ladies and gentlemen, and a very warm welcome to all of you. I'm your virtual host, Diksha Rena, and it's my pleasure and privilege to welcome each and every one of you to this eventful evening at 72nd Annual DOS International Hybrid Conference 2021 at Hall A. To begin with the next session of the day, on Cornea Society of India, I would like to invite our chairperson, Dr. Namrata Sharma, our co-chairperson, Dr. Geeta Iyer, co-convener, Dr. Santosh Suman, our convener, Dr. Jaya Gupta, and our moderators, Dr. Sharon D'Souza and Dr. Nidhi Gupta. To begin with the session, I would like to hand over to Dr. Geeta Iyer. Over to you, ma'am.
Thank you, Deeksha. Good evening, friends. It's a pleasure for Cornea Society of India to present this cornea session in DOS 2021. At the outset, let me thank all our members of the society who have graciously agreed to be part of this wonderful session, who are going to be speakers for today's evening. Aptly titled What's New, the topics for the evening will cover recent advances through the entire spectrum of cornea and ocular surface diseases. Without any further delay, I will hand over the proceedings of this session to Dr. Sharon D'Souza to take it forward. Over to you, Sharon.
Thank you, Geeta. It is looking like a women ophthalmic, no, except for Swapnil, like a women ophthalmic society.
No, we
And
have
Dr. Santosh.
we have Jayesh, Santosh.
It is also there.
Swapnil.
Videos, we are the only ones who are visible. That is why.
Right. Good evening, everyone. And again, a big thank you to Dr. Namrata, Dr. Geeta, for having us all being a part of this wonderful session, both on behalf of CSI and DOS. So without further ado, we'll start our talks. As Dr. Geeta was saying, it's a potpourri of various conditions across the entire spectrum of cornea. And we'll try to highlight some new points or techniques or advances through the different topics. And I'm sure it'll be a very interesting session. I request all the speakers to be very prompt and keep to their time so that we have adequate time for discussion. Our first speaker for this evening is Dr. Santosh Suman. He's completed his master's from Allahabad and followed by a long-term cornea fellowship from Arvind Eye Hospital, Madurai. He's worked as the head of the cornea department at Thakurbhai Patel Eye Institute at Vadodara and is now the medical director at Cornea Eye Hospital, Vadodara. He will be speaking to us on unusual keratitis scenarios. Over to you, Dr. Santosh.
Thank you, Dr. Sharon. Good evening, everyone. Good evening, Namrata ma'am. Thank you for giving me the opportunity. Is my slide visible?
Yes, sir.
Yes.
Fine. So the topic given to me is unusual keratitis. In our practice, this is a case where in my practice, I rarely see such patients where the ulcers are of, very small size and they come at initial first or second day. This patient was referred to me because the patient had central ulcer. And on looking, it was having typical wreath pattern. So we can guess by look itself that probably it was a case of nocardia keratitis. And we scraped, it came out to be the same on both KOH as well as grams. The topical drop was started and it got healed in 2-3 days. But this is probably not the real life scenario. Most of the patients which we see, they come at various stages of ulcer. Patients also become serious about their condition only when the disease is very advanced. We are definitely dependent on microbiologists reporting, and most of the time we are guided by them, but sometimes we are getting misguided by them also. Patients compliance, follow-up, all these are very important. Availability of various fortified drugs at periphery, all these are challenges to us. And control of systemic diseases like diabetes and rheumatoid arthritis, which many times they don't take as seriously, are definitely a challenge. Ulcers usually take much more chair time than other diseases, and patients are many a times dissatisfied because of residual scar and other factors. So with this background, I would like to share some of my cases through which I learned a lot in my practice. This was one of the cases, I can say, unsolved mystery. This was a 55-year-old male who was referred to me urgently to have a look on this patient, but the patient had minimal complaint of mild blurriness in this eye. On examination, the patient had a deep sort of infiltrate. The infiltrate was hanging from the endothelium. The stroma was totally clear, epithelium was totally clear, and minimal congestion was there, and AC entry chamber showed only few cells. On careful examination, I could see a focal superficial scar, which gave me, sort of a thought that probably it could have been a sort of entry wound of a thorn or something. Probably the patient would have missed and would have let the infection inside. And I thought probably it could be a fungal or something. So thinking that, I started the patient on antifungals, voriconazole and ampho-B, and waited for some time. I used to call the patient every week, but patient was neither worsening nor improving. And the patient also gave history that the patient was given topical steroids. With that also, it was neither improving not worsening. So after a month or so, patient was fed up with all those drops and said that I just want to stop all those drops because nothing is happening, whether it is worsening or improving. And he lost to follow up. After 6 months, he came to me and everything was resolved by itself. It was only a deep sort of scar, sort of plaque. So retrospectively, I analyzed what was it, fungal, viral. The mystery is still unsolved. Probably I could have requested for a PCR, or probably a confocal would have done, which both of which was not available to us. And the important part was that patient was never so worried about his condition as we treating doctors were. Coming to second case, this was a patient, 46-year-old male, who presented with ring infiltrate. So clinically, we thought it could be acanthamoeba, bacterial, fungal, anything. Hyphae was seen on KVH and microbiologist reported as fungal. But then after a few days, microbiologist reported again that Pythium is growing. So this is a new bug which is there in our practice, and we are learning a lot. Initially, probably we missed few years back, probably we missed so much Pythium. We were thinking that these are non-responding fungal ulcers. Another case where which highlights that sometimes microbiologists can mislead also. So this was a case of a 12-year-old boy who presented with this central ulcer with feathery margins. It looked typically a fungal ulcer. When I scraped, I could see that septate, branched hyphae are there. But after a few days, my microbiologist called me enthusiastically that there is Pythium growing in both blood agar and SDA. But I called the patient again next day so that I can start the patient on linezolid and other drops. But then that time I saw that the patient was healing, the margins were healing, and I saw some pigments over that. So this was giving me the clue that probably it was a case of dementatious fungus. And then when I consulted with my microbiologist, they say that yes, dementatious fungus is growing. So with this, I learned that initial growth of dementatious fungus might resemble Pythium. So we have to be careful in hurriedly coming to the diagnosis. And this patient is definitely healing well with topical antifungals only. Another patient who was referred to me as a case of sudden onset of focal corneal edema. So the patient had mild congestion and focal edema was there along with few cells in the anterior chamber. And on examination, I couldn't see much of infiltrate, but on scraping, it found out to be branch septate hyphae on QH. And it was a typical pseudo-dendritic pattern was there. Antifungal was started and patient got healed finally. This was a interesting case where which shows that history is very important. It was a 55-year-old male who came with a ring infiltrate. There was no history of trauma, no history of contact lens wear. And on examination, there was gross congestion, there was ring infiltrate, there was edema over the peripheral cornea. There was a sort of split in the cornea, the DM detached sort of thing was there, which was seen on the infield part of the cornea. It probably happens with when a lot of inflammation is there. I could see almost less than 1 mm hypopyon, and central area of the cornea was very clear, and total stain was there. So I scraped and KVH was negative. Gram showed only few pus cells, but nothing came in that. So the patient was started on antibiotic cycloplegic, but poor response was seen. But the next time when I again took history, the patient said that he had accidentally put some Ayurvedic ear drop in that eye. So now I thought probably it could be some sort of toxic keratitis. I gave a challenge of steroid and called the patient next day, and patient was healing beautifully with that. So probably it was a case of toxic keratopathy where patient had used these spurious drugs. And in 3 weeks, patient, you can see that he's healing very well. Another patient which shows us history might be sometimes misleading also. This was a 12-year-old boy who was being treated by general ophthalmologist. There was a history of acid spill 7 days back, and patient was on Vigadex eye drop, CMC eye drop, and LMC tablet. When the patient was referred to me, I couldn't find that there is any sign of chemical injury in that eye. There was area where subclavicular hemorrhage was there, ulcer was definitely there in the center, and the inferior part of the inferior bulbar conjunctiva, which should have been affected by an acid, was not found. So I thought of scraping, thinking as infective etiology. On scraping, I could see that the involved area was very fluffy. Cornea was sort of melting in that area, probably because of the use of steroid. And it turned out to be gram-negative bacilli. So history was misleading here. Probably patient thought that because of some acid it happened, but it was actually a bacterial keratitis. Another case, very interesting case, a one-eyed 76-year-old male patient who presented to me with this type of focal epithelial defect around, along with surrounding epitheliopathy sort of thing, you can say, with early DM folds. I thought it could be because of a foreign body has surged on inverting the lid and everything. I couldn't find anything. I just gave the patient antibiotic and lubricating drops. After 7 days, it actually worsened. The epithelial defect increased, and the area of epitheliopathy as well as DM folds, that also increased. I just continued the same search for foreign body again, couldn't find again. Then next time when the patient came, I could see one small furrow. This furrow, in my practice, I have learned that if it is pythium, furrow is definitely going to come sometime. In most of my patients, I have seen all those pythium patients, this furrow comes. Then we scraped again, we found it as pythium, and then after 2 months or so, patient healed completely. Another furrow I just wanted to highlight with this case, this patient was getting treated as fungal, but seeing furrow, we suspected pythium, because many times microbiologists are also confused, especially when when nothing grows on culture. They are confused between fungal hyphae and the hyphae of pythium. Another case where again, because of these furrow, we could suspect as pythium, but unfortunately it didn't respond to topical medication, and we had to do a transplant. Thank you.
Excellent set of cases, Dr. Santosh. What a variety, stretching right from the various infective conditions to the toxic. In your practice, how much, so the same scenario which you're talking about, that sometimes, the microbiologist report may be misleading, or they ask us to clinically correlate or give some sort of thing. So in those situations, would you re-scrape, or would you start an empirical treatment and get back to the patient, call them how frequently? What is your protocol?
Follow-up, whenever I start patient on any drug, my first follow-up will be either second or third day. If it is, if I feel that everything is fine, falling in line, then I call them every week. And re-scraping, yes, if we don't find anything, we definitely re-scrape.
And with this last 2 years with our COVID pandemic, has anything changed in the way you practice or treat these patients, or ask them to follow up, anything?
It had changed earlier, but now everything is getting fine. I think now everyone is coming back for follow-ups and all. Yes, last year we had issues with that. We did telephonic consultation also, all those things, which it could never suit me. Teleconsultation I never liked, because they are not able to take pictures. It's very difficult to come to a conclusion for at least cornea practice. I'm very not satisfied with teleconsultation. But now things are almost normal, at least in Gujarat.
Very important, very interesting point about the furrow. I think it's quite an interesting clinical finding that we'll all look out for. From all the other panelists, anything you'd like to add from your experience on any unusual cases or how to manage them?
I might just say a word here. It's excellent cases, Dr. Santosh. I think you said, following up the patient, and rightly, as you mentioned, revisiting the history, re-scraping and revisiting the history is something that is of importance in these patients. PTM is something that we have learned and we've understood over the last few years that it needs to be your differential when you're dealing with fungal lookalike infections. Smaller ulcers do heal with the medical management, but the larger ones require surgical intervention. And the point that you mentioned about asking for any toxic contributors, and this is something which can significantly mimic and create a dilemma in your diagnosis.
Yes, ma'am.
Thank you, ma'am.
Thank you.
So we'll move on to our next talk for the evening. I welcome Dr. Pallavi Joshi, who finished her master's from WIMS Bellary, followed by a long-term cornea fellowship from Arvind Eye Hospital, Madurai. She currently works as a consultant cornea and ocular surface at Shankara Eye Hospital in Bangalore. And special interests are definitely work in ocular surface and keratoprosthesis. She's one of the first in Karnataka to have performed these surgeries, and a lot of work in pediatric keratoplasty. She's going to speak to us about her work on sural nerve transplantation and how to help these patients. Over to you, Dr. Pallavi.
Thank you, Sharon. Am I audible?
Yes, yes, and your slides are visible.
Yeah. So yes, I will be at the outset. Thank you for DOS and CSI for this opportunity. So I'll be speaking to you about the healing of an insensate eye. As we are all aware that the cornea is the most densely innervated tissue of human body, and its corneal nerves are essential for maintaining the ocular surface integrity. The corneal nerves produce the neuropeptides, and these allow the healing of the corneal epithelium, migration and adhesion. And in return, the corneal epithelial cells also produce neurotrophic factors, which lead to the promoting of neuronal extensions and survival. Thus, this balance is vital for the corneal healing and maintenance. Anything that causes this to go bad will lead into something called as neurotrophic keratitis or neurotopic keratopathy. Many causes are there. Of the ones which are most common we see are the herpetic keratitis, as well as chemical injuries, or any damage to the trigeminal nerve, especially the ophthalmic division, will lead to an insensitive cornea. Congenital corneal anesthesia, though rare but is known to occur, we see it in children, and they are typically bilateral and have a poorer clinical course than the acquired ones. So this Mackey has classified it as stage 1, which is a mild variant with corneal punctate keratopathy, stage 2 with persistent epithelial defect with a little bit of edema. And if these are not treated timely, they can even go for worse situations like stage 3, where ulceration and perforations occur. And once the perforation occurs, obviously the eye is lost. So diagnosis is history, and the most important aspect is the sensation, which we check either by qualitative or quantitative assessment. The stage 1 and stage 2 are mainly treated with medical management with use of lubricants, finding the cause for it. There are a lot of drugs that have actually been novel in treatment, of which the only one which is approved and which we are using is the new nerve growth factor, which is a recombinant drug available, which has to be used actually every 2 hours for 8 weeks, and it comes in single cartons. The way it acts is it basically supports the epithelial cells, stimulates the growth, and allows the limbal stem cells also to be maintained. It is also known to act by acting on the lacrimal glands and promote tear production. However, exact increase in the renovations are not known. Stage 3, this is a stage where already perforated and bad, where conventionally we use amniotic membranes, or we use patch grafts, or we use the tarsorrhaphies. Sometimes we end up doing grafts also. But because of the primary absence of trophism, these corneas eventually actually get perforated or they are lost, and we are not able to visually rehabilitate. Here comes the role of corneal neurotization. What is it? It is a surgical procedure where involves the transfer of a healthy donor sensory nerve axon to the denervated cornea, and it is establishing the new nerves. This was first introduced by Tres in 2009, and we have come a long way, and it has been very successful. There are basically 2 types of neurotization. One is the direct, where we transfer the contralateral supraorbital or the supratrochlear nerve to the anesthetic eye. Here, a big, large incision is made actually around 3 centimeters beyond the nerve, and it is exported and brought through the subcutaneous area to the eye where it has been applied on the perilimbal area. A modification of this has come where they are using endoscopic guidance where it is little minimal. The advantage here is the nerves are easily accessible and single location scar, and it avoids the nervography complications like neuroma. However, because we have to take the whole nerve, we don't know what is the length. Sometimes it may be insufficient and we can cause iatrogenic injury because of lot of manipulation. So what is the next technique? The next technique is the indirect neurotization. What is this? This is also called minimal invasive corneal neurotization, where we use a interpositional nerve graft. This could be all over autograft, which acts as a conduit, which connects the donor sensory nerve, here being the orbital nerve or the trochlear nerve, to the eye, which is not having sensation. So what is the advantage here is, here we are able to access to the proximal aspect of the supraorbital nerve, which has a lot of axons and helps in better regeneration. It's minimally invasive. And the best part is the area which is actually donating its axons is not desensitized because it is not cut and there's a lot of flexibility. However, because we are using an extra interpositional graft here, the regeneration of the corneal nerves takes a little longer time than that when we do a direct nerve transplants, which I spoke about before. So what are the grafts used? There are a lot of grafts which are used. Sural nerve is one, and endobrachial and greater auricular. So at our institute in 2018, we actually began this procedure. At this point, I would like to thank Dr. Sunil, who actually handled and taught us, and Dr. Saptagirish, who is our oculoplasty surgeon, who helps us to procure the sural nerve. So here, this is a combined procedure where simultaneously, actually, I'm doing a DALK procedure, and here we are procuring the sural nerve. Here it is very carefully we identify the nerve, and the saphenous vein is the guiding principle there to identify it. So we take around 4" or around 10 to 12 centimeter of this sural nerve, and we measure it, and it is then passed through. Now here we have made a subbrow incision on the donor side where we actually look for the supraorbital or supratrochlear. We are very comfortable with supraorbital because its anatomical variability is less, and here we have actually tracked it and held it up. Here already in this place we have finished the DALK, and this is the distal end of the sural nerve, which has actually been passed through the contralateral brow incision, and the epineural sheaths are separated. We pass this through small subconjunctival openings and create a corneoscleral tunnels. Some people do not create the tunnels, they directly innervate that area with the sutures. The main important thing is we have to be very careful, and we should make sure that it is atraumatic for the nerve endings. So once we pass this, there are around 5 to 6, more the merrier here. We should have more fascicles so that it is surrounding all over the perilimbal area. There's no need directly to put these nerves into the cornea. If we are placing it at the perineural area, as we all know, that it is not just the direct innervation, but even the paracrine function of these nerves helps in bringing back the corneal functioning to a great extent. This is sutured into the tunnel either with 10-0, or people have variations like using fibrin glue, or even amniotic membrane is used as a scaffold. The main intent of using these additional things is to make sure that there is no slippage. But eventually, the studies have shown either way, at the end of 6 months, majority of them come to the same level of renovations as they have seen through the studies. So now the distal end is closed here, and we go to the proximal end of the sural nerve, which is taken out, and we actually do a coaptation. Here we do the end to side. So we do not open the supraorbital, we just open the neural sheath and attach it to the proximal end of the sural nerve through a 10-0 suture. This helps in the attachment, and this is the end of the procedure. So apart from sural nerve, the advances nowadays are people are using a cellular nerve allograft, which is actually prepared in the labs. And this advantage is it is non-immunogenic, and it helps in preventing need of a second surgical set of team or scarring at a donor site. However, the cost and commercial availability of this cellular nerve graft is something as a limitation. They have a few studies where they've used processed cadaveric nerve grafts. However, they are retrospective studies, not very conclusive, but they say that yes, they also give as good results as this. So with this, our experience in the last 4 years is we have done around 5 cases, and majority of our cases have been either the viral, the one which we showed, and one in whom it was post-traumatic, and a couple of them were congenital corneal anesthesia. We had our shares of setbacks in the form like whenever we have done a PK along with that, the healing takes a little more time as compared to when we have done lamellas like the Dahl procedure. And a patient being unhappy because of a cosmetically thick fascicular seen subconjunctival has also been a part of the thing we have seen. Limitation with confocal because we had a lot of children was there. However, in one patient, we have done up to 18 months also. So to conclude, neurotropic keratitis is rare, but it is present, which we see, and it's very challenging. And the mild forms can be managed with the neurotropic drugs, but however, only in mild to moderate cases. The corneal neurotization seems to actually hold a key to promising outcomes, which are reproducible and even in advanced diseases. And it is possible actually if we combine these drugs like the nerve growth factor along with the neurotization, which actually add more complement to each other. However, still at for date, we do not have comparison studies, but in near future, I hope we would be able to get a clear picture about the same. So with this, I would like to end my talk and thank you.
Thank you, Dr. Pallavi. It was indeed a lovely presentation, very clear and beautiful videos on how to perform the procedure. So how do you follow up these patients? How soon would you expect the nerve regeneration? Is there anything like that? And would it depend on what is the underlying pathology to start off or the severity of disease?
What we have seen is that with respect to the clinical condition, we find the patient improving. The indirect effects of trophism, like patient sensation, we have seen as early as 6 to 8 weeks. However, initially the patient, when we had, it was a nice experience. Whenever he used to touch the patient's cornea, he used to tell that he feels at the contralateral area of the supraorbital. And as it progressed, eventually over 6 to 8 months, he's able to appreciate that. So that is the first one we see. And then, so we call at the end of 1 month, then we have seen at 3 months, then we have called them at 9 and year, and then yearly is what we have been following them. So that is our normal protocol with this. And we have to do the suture removal at the donor site. So that requires the patient to come back after 2 weeks also at the leg space.
And any follow-up required with a neurologist or any medications from that side that they put on? Because we don't have the Oxybate available to us.
Yeah, Oxybate is not available. I had only one patient who used to get it from US, but here we have not actually had anyone. I have not started anybody with concomitant Oxybate to any patient till date. So we just maintain them on typical steroids, and sometimes we choose between putting some amount of phenylephrine, sometimes along with tropicamide, and that tends to help the way we look after. But we maintain patient on steroids for over a period of 3 to 4 months for sure.
And this would be PRED or any softer steroid? Softer
steroid, depending on how the ocular surface is, because all conditions are not same. That's how. Especially when you're
tarsorrhaphy required with this?
With the PK, yes, we learned it that with PK it is better to do a temporary tarso for at least 2 to 3 months. That helps. Yes.
Any of our other faculty would like to ask or comment on this from their experience? Okay, with that, I'll hand over to Dr. Jaya Gupta, who is also moderating with me today. Dr. Jaya, you're mute.
So the next speaker for today is Dr. Sharon herself. She is consultant in the Department of Cornea and Refractive Services and coordinates the Ocular Surface Clinic at Narayan Nethralaya. She completed her medical education from St. John's Medical College in Bangalore and completed her post-graduation in ophthalmology from the same institute. Fellowship in Cornea and Refractive Surgery from Narayan Nethralaya, and also an observer at Singapore National Eye Center. Her areas of interest include ocular surface related conditions, keratoconus, and refractive surgeries. She's currently doing her PhD on the ocular surface immunology and immune cell profiling from the University of Maastricht. Over to you, Sharon. Her topic is DALK, whether to bubble or not to bubble.
Thank you, Dr. Yeah. Are my slides visible?
Yes.
Right. So yeah, this is almost a Shakespearean question that we are often faced with. But apart from the literary background, it's definitely a relevant question because it's not just about when to bubble or not, but there are things which go wrong or things which are difficult to deal with, and that's what we'll try to discuss through this presentation. So, of course, the reason for doing a DALC is there are multiple, benefits that we have. Primary being that there's a reduced risk of graft rejection, which we see with full thickness keratoplasties. The wound strength is much better, less risk of intraoperative complications, and of course, the patient recovery is faster, and we can taper steroids. So again, less risk of complications. The indications are, multiple, but the most common again is conditions in which there's advanced keratoconus with a lot of ectasia, other conditions of ectasia, and corneal scarring involving mainly the anterior parts or at least the posterior till the posterior stromal parts, including corneal dystrophies. So it's very important that when we are doing the DALC, we have to keep certain points in mind, including what is the underlying pathology. And of course, as I was discussing, what is the depth of scarring and the pathology which is seen. And the anterior segmentosity is extremely useful in these because then we can measure the scar depth. The size of the involvement, which is whether it's central or how much of the periphery is involved, because we have to decide the size of our grafts. Of course, as we said, then the involvement of the endothelium or the Descemet's membrane, including with scarring or other conditions, has to be noted. So it's important to differentiate when we see a scar there. So many of our advanced keratoconus patients do have apical scars, especially if they have been long-term contact lens users. But it's important to differentiate a hydrop scar from a non-hydrop scar because if you're trying to or planning to do a bubble, then a post-hydrop scar can give way, and it's important to note that before. There are various techniques of doing a DALC. Big bubble technique is one of the more popular ones, but of course, the manual dissection technique, whether it's with scissors or with other instruments, is invaluable because it is our fallback technique when we cannot bubble. Other techniques like the stromal delamination or the Mellis technique are also important. There are various instruments that we use. Most of them are very commonly available to us in our operation theaters, but what are invaluable or definitely need to have are the guarded knives, which would be the depth would depend on what depth you want to have your anterior dissection at, either a 30 gauge needle or a cannula for making the bubble. And the blunt tip scissors, I think, is something which is really very, very important and you must have before you start these surgeries. So just a simple DALC to start off. And because we're concentrating mainly about the bubble, this is straight to the bubble step. But what we have to keep in mind is where the tip of the needle or instrument is, which you're using for the DALC. So the location. So ideally, it needs to be as close to the center as possible. It needs to be directed at the center, and you should be able to judge the depth. It shouldn't be too superficial. Otherwise, you're not going to get the bubble. And of course, if it's too deep, you're going to perforate. Usually we would prefer to not have the bubbles coming outward. And if you see the bubble coming outward, you ideally should stop and start from a different section. The next step is then to release the bubble. And here I put a drop of viscoelastic on the cornea to prevent a very rapid egress of the air and touching of the DM with the blade. And you can see the egress of the air from it. It's important to put an air into the AC as a, it's almost like a marker, because as you release the bubble, the peripheral bubble in the AC comes to the center and you know that your air has released. The next step is the posterior dissection of the stroma. So once you've made that nick in the posterior stroma, you can very neatly remove the posterior stroma into quadrants and get a very clear DM bearing. But of course, things don't always go according to plan. And if preoperatively itself, we've seen that there is a deep corneal scar or it's a post-hydrops eye, then we may decide not to do a big bubble. And here the manual dissection techniques, either groove and peel or Mellis techniques or any others, are very, very useful. And I really think that it's mandatory to sort of master these techniques because you never know when you would need to use it. So the challenges with the big bubble can be multiple, but it's important to understand your instrumentation, understand the direction of air and how it's flowing, what is the pressure required when you're injecting that air, and what is the type of tissue separation that you're seeing. And once you understand this and the sort of flow between all of these factors, then it's easier. So very often when we're training doctors, we get this question is, how do I know that the bubble will form? And I'd like to show this video. And if you can concentrate on the two red arrows and just look in those areas, you can see these small spokes kind of separation of the stroma. So even though the air is coming back, and what I said earlier is if air is coming back, you're probably better to stop and start from a different area. But when you see those small spokes or separation of stroma, it's a sign that probably you're going to get your bubble, and you should keep injecting and not remove the needle or instrument out. Just to highlight what I mean by this spoke, you can see the other video where it is just an opaque bubble layer. It remains like a blotch there. It doesn't really separate the stroma. And that is the difference. If you see that you're not going to get a bubble, have to stop and come out. The next question is, how many times can you try the bubble? Now, it's important to understand that every time we make a bubble and it is just an opaque bubble layer, there's a stromal separation, then it's more and more difficult to get a bubble. As you can see in this condition where the doctor has sort of injected and there's multiple small bubbles all through the stroma. You can still go in and try, and there you can see that the deep, the big bubble has formed. But as the air tries to go into the area of least resistance, it's more difficult as with the number of tries. So it's ideal to try and get it early, but there's no hard and fast rule on how long or how many times you can try. The next is what to do in case the air enters the anterior chamber. And this is something that many of us might have encountered and can happen, especially if the needle is far away from the center. You see the air goes outwards and then comes circumferentially and through the trabecular meshwork into the AC. Now, it's important to differentiate this from microperforation. So if your needle was towards the center and the air came in directly into the center, then it's more likely that you've made a microperforation. Whereas in this case, very clearly, you see the air tracking from the periphery into the eye, and that indicates that it's come from the trabecular meshwork. And so you can try from a different area. Now, another situation that may be encountered is that you got the bubble, everything was fine, and it went very well, and you release the bubble as well. But the plane of dissection is not found. As you can see here, you got the bubble, but somehow it's difficult to pass the scissors. The plane of dissection is not visible. So this is usually that the nick which was made was very small, and so the air has escaped out, but it's not large enough for the scissors to pass through. Here, what we call the needle technique, or passing a very small instrument and enlarging that nick, will save you a lot of time and effort. And then you can find the plane much more easily and go in and do your separation of the posterior stroma as you're used to. Of course, there are conditions where you cannot do a big bubble DALC, and we do a manual dissection. And if we manage a good predesmetic dissection and go as close to the DM as possible, the visual outcome and anatomical outcome is extremely good. It may be a little slower. And this was a boy who had advanced keratoconus in both eyes. The right eye was scarred and we had to do a manual dissection, and the left eye had an advanced KC but was not scarred. So we could do a big bubble. And as you can see, the anatomical changes initially, of course, there's a lot of more edema, and it looks, the graft host junction looks a little more edematous, but over time, when it settles, they do extremely well. So the idea is to try and get as close to the DM as possible. Of course, no surgery has no complications, but still, I think when we have a chance, DALC is always a good option for these patients. Thank you for patient listening. I'll stop my slides.
That was wonderful, Sharon. I have a question. Beyond the complications, I mean, I think you enumerated only the post-op intraoperative complications, right? In your last slide. So I recently encountered a patient who developed something like a Urit-Zavalia syndrome. Have you had any experience following DALC of Urit-Zavalia? Because
Did you have to leave a large air bubble in the AC for any
that
reason?
was a manual DALC. That was a manual
You
DALC.
didn't have to.
No, that was a manual DALC. I don't remember. Maybe in the end of the surgery, I did keep a bubble.
Because that would be the only reason. I've seen it in patients who, one patient who I had to leave a bubble because of I felt that it may not oppose because it was a very advanced KC. So then I did have a dilated pupil, but other than that, without leaving a bubble in, I haven't come across. So because there's nothing to dilate the pupil per se. So.
Any other questions, or then we can move to the next speaker?
Yeah, we'll move.
So our next speaker is, I think, Dr. Swapnil.
Yes.
So Dr. Swapnil is presently Director of Vision Care Center, Super Specialty Eye Hospital, Shirur and Shikrapur. And he's done his MS from Postgraduate Institute, Chandigarh, and a fellowship in cornea from LV Prasad Eye Institute. He's got a special interest in ocular surface diseases, and he's got 15 index publications to his credit. So over to you, Dr. Swapnil. He's going to be talking on desert to oasis minor salivary gland transplant.
Hello. Thank you, Sharon, and for this kind invitation and giving me this opportunity. We have already discussed this minor salivary gland transplant many times. And I'll just go through some basics about it so that, those people who have not heard about it, they would come to know what exactly it is. So what are minor salivary glands? They are distributed throughout the oral mucosa. They have a compact layer. They form a compact layer just beneath the mucosa, and each gland has a single lobule, which we can see over here. So this single lobule, if we just go and trace it over here, we can see that this single lobule forms a gland which has a duct, and it has a serous gland. That duct opens onto the surface. If we look at the secretion, they are spontaneous. They have a higher viscosity than tears. They have antimicrobial peptides also, and also lipid levels higher than other salivary glands. This goes without saying that this particular transplant we perform for non-Sjogren syndrome dry eyes, especially SJS. Steps mainly involve making a conjunctival pocket in the superior bulbar conjunctiva, and then bridling the muscle, and then the mucosa salivary gland complex we fit into this pocket, and then once it gets vascularized, it starts secreting the secretions onto the surface, and then it comes onto the cornea. Important factors while doing the transplant: the size of the graft is very important, because the larger the graft, you have more number of glands, and single gland secretes about 0.1 microliter per minute per gland. So you should try to have a larger graft. Inclusion criteria, as I said, SJS patients with constant and disabling symptoms with preoperative Schirmer value may be 0 to 2, and we cannot do it in active infection or dry eye due to primary or secondary Sjogren syndrome and xerostomia. There have been attempts of doing salivary gland transplants. People have placed it into the fornix, on the tarsal surface, and on the lower and upper fornix both, all around the cornea. And there have been good results. People have published about different techniques. But what is the main cause of failure in all of these studies were that the glands developed a subglandular fibrosis, and that's how they stop functioning after some years. So however technique differs with these techniques is that here we can see that the glands are directly exposed onto the surface. However, here we can see in our technique, we have glands over here, and there is a muscle layer which is preserved. So this is a basic difference between previous technique and our technique, that we preserve a muscle layer covering the gland, and which theoretically prevents the fibrosis between glands and ultimately failure of the transplant. Thanks to Jayesh, we recently published the results and long-term outcomes of a modified technique, and we'll be discussing the same technique. So shortly, So if we look at the technique, we can see over here that we make a superior conjunctival incision as large as possible after building the superior rectus muscle. And then we also dissect the tenons posteriorly, but we do not dissect the tenons anteriorly so that the secretions will not escape anteriorly and form a bleb like a trabeculectomy bleb. The second video, we can see how we harvest the gland. We usually use the lower lip mucosa, or you can also use the buccal mucosa. And you can usually take a D-shaped graft for one eye because glands are maximum in the center. While you are harvesting the glands, it is very important to go slightly deeper compared to what you do in MMG. You can see I've turned my scissors down and I'm trying to preserve the muscle over the glands so that, that muscle layer is very important. And this third video, you can see I'm trying to trim the graft where, I'm trying to trim this muscle and preparing the graft. And fourth video, you can see how to suture it. So this is how this first suture is very, very important in the fourth video, that I'm passing the suture to the muscle underlying the glands as well as to the superior rectus belly. And now the gland will rest firmly onto the surface. This is very important for the quick vascularization because it is a bulky mass. If you do not place it onto the superior rectus belly, then probably it will not get vascularized and it will have ulceration and fibrosis, and then glands won't function. So this is how we suture it at both ends. First suture is on the superior rectus belly, second is onto the sclera, and then third is just suture the mucosa to the conjunctiva. Try to assure a tight seal so that the conjunctiva won't grow over the mucosa, and also try to avoid the ulceration onto the mucosa so that there won't be any conjunctival growth. So this is about technique. We'll see the results. So we can see this case one, 25-year-old male teacher, history of HS 10 years back. You can see in the video he has severe photophobia. He's not even able to open his eyes for taking the video. And I did the minor salivary gland transplant for him 4 years back. This is day one photograph. You can see glands are lying nicely onto the surface with whitish appearing glands, and then later on, once they vascularize, you can see transillumination of the glands because of secretions. And this is 4 years. Now in here, the superior part is conjunctivalized, so that is non-functional part now, but you can see the lower part is still functional, and that patient is still maintaining a very good vision. You can see he was not able to open the eye preoperatively, but now even after 4 years, you can see he can open the eye very clearly. There is minimal staining on the surface and the eye looks quite wet, and he's symptomatically very happy. This was a case of SJS where I decided not to do a K-Pro, and I just did a allogenic slit from mother along with minor salivary gland transplant, and she could maintain a counting finger at 3 feet vision for 1 year. After that, she was lost to follow-up. This is again a 55-year-old female with SJS. You can see right eye has a right and left eye both has a keratinized surface. I did a MSGT for the left eye, and you can see these are early post-op photos. You can see the wet eyes, and this is almost after 2 years. You can see glands onto the superior bulbar surface and the wet surface, and she is also maintaining ambulatory vision. This is again a patient of SJS. You can see photophobia in the first photo. You can judge there is a lot of photophobia, and after 2.5 years, so here you can see in the early, this post-operatively, the glands are nicely wet and they are producing a lot of tears onto the surface. He is able to open his eyes very nicely. This is another case where keratinization has decreased following 2.5 years after the SJS. The glands are nicely sitting and we can see wet surface. So most of these patients, this patient I did MSGT in left eye, but not in right eye, and you can obviously make a difference between the two eyes. So most of the patients were very happy post MSGT. This is only case where I did it in OCP, and you can see a slight difference where the surface was completely opaque and vascularization has decreased post MSGT, and she is maintaining ambulatory vision. But really, I don't think it would work for a long time in MSGT. You can actually measure the salivary gland secretion by just placing a fluorescent strip over the glands and seeing under fluorescent light, and you can see like Siedel's test. You can see the glands producing the secretions. Similarly, we can check glands onto the lower lip if you have a doubt that whether there are functioning glands or not. This is the paper. If you want to read further about it and about the results, you can go ahead and read this paper in BJO. Which talks about the long-term outcomes. So we had 21 patients with median follow-up of 3 years. all of the patients showed significant improvement in Schummer scores, conjunctival and corneal staining scores, and the visual acuity also improved in most of the patients. And also because it is a relatively harmless procedure, so there are no sight-threatening complications as such at the donor side as well as in the eyes. This is you can see the long-term outcome. So the figure A and is a 1 year after A, and A is a pre-op, and then 1 year after surgery. And then you can see C, D, E, and F. The progressively there is decrease in corneal vascularization and scarring as well. So this is ultimate outcome where you can have a decrease in vascularization and scarring as well. Thank you so much. Am I audible?
Yep. Thank you, Dr. Swapnil. That was really an excellent talk and beautiful videos elaborating each step. And that is what we wanted to bring out, that what is that modification of technique which is making it, so much more successful than previous attempts. This is, as you said, it's not a new surgery. But I have two questions which I'd like to ask. One is, you are fixing it to the superior rectus muscle.
Belly, yeah.
Yes. Are you? Were there any conditions, or is it possible that these patients may have any movement restrictions or any issues because of that, or you've not?
Not really. No patient had. In fact, I fitted 2 patients with scleral contact lens after MSGT because
that was my next question.
Yeah. So I fitted 2 patients with scleral lens, also modified scleral lenses from LVPI, and they are doing really well because they are tolerating lenses very well, and also they have to change the saline very less often.
Okay. When you say modification, is it a modification to allow that the area of the MSGT, or what was the
modification? Number 1 is we preserve the muscle layer over the glands, or
of this lens, of the scleral lens. Does it need any modification?
I'm not really doing it myself, but they have a software where you see a compressed area or blanching at certain point. Then they modified the haptic in that particular quadrant depending on the software. So I really don't fit it myself. Dr. Sonal does it, and she has modified it for those patients. Yeah.
Okay. But you haven't had any patients who feel the cosmesis outside?
No, not at all. Patients even do not know what is there. There is something, and you even cannot identify if you don't lift the upper lid and see. You won't come to know that we have done MSGT because it is deep into the fornix.
Really very gratifying to see, even in very advanced keratinized surfaces of SJS.
Yeah.
The results are really, really gratifying.
I think another advantage of this technique is the site of placement is onto the suprabulbar conjunctiva, so that whenever the lid moves, because secretions are very thick, they won't flow on themselves onto the surface. So whenever the lid moves, it's kind of a viper movement, and it takes the secretions down onto the cornea. So I think that is one of the advantage of this technique, that by placing it over the suprabulbar conjunctiva or surface. Yeah.
Nice. Dr. Jayesh, I know you've worked a lot on this. Any additional comments or suggestions?
He's probably covered it all, and there's the paper which nicely describes this technique and the outcomes. What I would just like to add is that just like everything else in SJS and these cases with severe ocular surface pathology, nothing is going to work magic. So anyone who is starting out should know what to expect in terms of both the clinician as well as the patient. So in carefully selected cases, there is definitely a role, but in itself, it's not going to solve all the problems for that particular patient. But it is definitely one piece of the jigsaw, and it is useful in the correct indication.
Very nice. So thank you, Dr. Swapnil. We'll move on to our next speaker, who is Dr. Jayesh Vazirani. Dr. Vazirani trained in ophthalmology at the Postgraduate Institute of Medical Education and Research, PGI Chandigarh. And he followed that with a long-term fellowship at the LV Prasad Eye Institute. He then worked as a faculty there and has been actively involved in a lot of research, clinical program training of residents and fellows. And he's now the director of Excel Eye Care. He has multiple publications and research work to his name. And he's going to speak to us about an extremely important topic of ocular allergy, because we see it day in and day out, and there are a lot of situations where just those drops are not going to help. Over to you, Dr. Jayesh.
Sir, first one, open PowerPoint.
I'm not sure what. All right. I think this should do it. Right. Are the slides visible? Yes. So thank you to DOS, Dr. Namrata Sharma, the CSI, Dr. Geeta Iyer, and of course, Dr. Sharon D'Souza for this invitation to speak. So I'm going to just highlight the advances in the management of ocular allergy that have taken place over the past few years. I have no financial interests in the subject matter of this presentation. So unfortunately, even as of today, most of the textbooks or the material that postgraduates go through or ophthalmologists learn have some dogmatic beliefs about ocular allergy. This includes both the understanding of these conditions as well as the treatment which is advocated. So it's commonly felt that ocular allergy is a disease that occurs in children in certain geographical conditions, in certain seasons, and it's usually quite innocuous, not vision threatening, intermittent. And the treatment is mainly giving lubricants, sometimes topical steroids, and at the most some mast cell stabilizers or dual acting agents. So over the next few minutes, I'll try and summarize how our understanding of ocular allergy as well as the treatments have advanced over the past few years. So now we know that allergic conjunctivitis or ocular allergy is not one disease, but a spectrum of diseases. I've highlighted VKC and AKC, that is vernal and atopic keratoconjunctivitis, as they have a slightly more severe profile in terms of symptoms. They are also diseases that are mainly driven by a T cell response, whereas the other forms of ocular allergy tend to be less severe. Within VKC and to an extent AKC, which behaves similarly, we now know that not all cases are mild, not all cases are intermittent, but you may have cases that are chronic, cases that are severe, and cases that may also have blinding complications for the patient. So this is something that has come into clinical practice recently, although I suspect subspecialists have always been seeing these cases for many years and decades. Now we have very good data from a very large data set, which tells us more about the demographics of ocular allergy. So this paper just summarizes that based on the data from India, maybe 1 in 10 children and adolescents will have allergic eye disease. The highest prevalence is in late childhood and early adolescence. It is more common in late spring and early summer, but there is sort of a baseline activity throughout the year. And it somehow is much, much more common in boys compared to girls. We now know that there are specific subsets of patients who continue to have persistent allergic conjunctivitis, a severe form of VKC, starting when they were children and persisting throughout adolescence and even into adulthood. There is another subset of patients who develop the disease de novo in adulthood. And even though the disease manifestations tend to be similar in all of these three groups, there seems to be some sort of difference in the biochemical profile of these diseases. For instance, this paper suggests that androgen receptor activity was much more in the persistent forms of VKC and the late onset forms of VKC compared to the childhood forms of VKC. And also the activity of pro-inflammatory genes on the ocular surface was more in the adult onset forms and the persistent forms compared to the childhood VKC. So maybe these are slightly different diseases. We know for certain now that there can be severe and chronic and blinding complications of allergic eye disease in the eye. The prominent one I've highlighted on this slide is limbal stem cell deficiency. So there is clinical evidence, there is cytological evidence of this entity, and there are lots of papers on this now. These patients, of course, can have keratoconus, which is well established, and I'm not mentioning this here. Akin to that paper, this is approaching it from the other side. Amongst all cases of bilateral LSCD in a large data set from India, we found that allergic eye disease was responsible as the underlying cause in about 1/3 of these cases. And these were very severe cases of limbal stem cell deficiency. The mainstay of treatment for these patients tends to be topical steroids in most cases. And that is why they have a certain percentage which will go on to develop cataracts as well as glaucoma. And this is a paper which highlights how serious this issue is. So that was about how the understanding of our approach to allergic eye disease has changed. We know that it can be chronic. We know that it can be severe. It does not affect only children, and it does not occur only in certain seasons. Likewise, over the past few years, there have been advances, albeit incremental, in therapy. So as far as topical therapy for VKC or AKC goes, it would suffice to say that the availability of topical tacrolimus, initially as 0.1% ointment, which was the dermatological preparation, and later as 0.03% in India, has helped to a great extent in the management of mild to moderate spectrum of disease. So the patients who would typically go on to develop severe forms of disease can be halted with regular use of tacrolimus ointment. And there's a large body of literature now to support long-term use of tacrolimus in patients with moderate VKC and AKC. To a lesser extent, there has been some work and some literature has come out on the use of systemic therapy for what is essentially a localized eye disease. So these are some case series, each of which has about 3 to 5 patients. One has 6 patients, which describe the use of systemic cyclosporin and tacrolimus in the treatment of atopic keratoconjunctivitis. Likewise, there's one case report from Dr. Nikhil Gokhale, which describes the use of oral cyclosporin for refractory VKC, as well as one case series of 3 patients who were given subconjunctival omalizumab, which is basically an anti-IgE antibody for VKC. So this was one of the patients whose images we used in the earlier paper that I mentioned. And this patient had very severe AKC, a 15-year-old boy. And the picture on the top is before the initiation of systemic therapy with systemic steroids and cyclosporin. And the pictures on the bottom are after a few months of systemic cyclosporin without any surgical intervention. So in selected cases, it can really have a dramatic impact on the disease. So I happen to have limited experience in my own practice over the past 4 years or so. This is not the patients which I was treating when I was associated with the LV Prasad Eye Institute. These are patients in my practice at Ahmedabad. So my protocol for these patients with severe or blinding disease who are typically steroid responders, who have associated comorbidities like cataract, glaucoma, is to use systemic therapy. So oral prednisolone, which is tapered over a period of 4 to 6 weeks and then stopped. And at initiation, I used to use systemic cyclosporin along with diltiazem to increase the bioavailability. Starting late last year, I have started using tacrolimus instead of cyclosporin, as it is equally cost effective now with multiple Indian manufacturers making it. And it is supposed to be more effective. So I have a few patients on cyclosporin and a few patients on systemic tacrolimus. When I looked at my data over the past couple of weeks for a collaborative study we are doing with Shroff Delhi on this topic, I found that I have 14 patients where I have initiated systemic immunomodulatory therapy for VKC, one of which was for AKC also. Of these 14 patients, this table shows 8 patients who have 6 months or more of follow-up. So you'll see that except for one, all of them were adults who had the persistent or the adult onset form of VKC or AKC. One was 16 years of age at the time of initiation of therapy. All of them had disease lasting for a minimum of 5 years, sometimes up to 10 years before we started this therapy. You can see in the comorbid conditions that almost all of them had multiple comorbid conditions, including liver stem cell deficiency, glaucoma, cataracts, etc. And I've used cyclosporin initially and later on tacrolimus. The 2 cases I've highlighted in red is patients who had raised liver enzymes, transaminitis, one of which was transient, and therefore we could continue cyclosporin in that case. The other case, we had to switch from tacrolimus to mycophenolate. All of them have a very good follow-up. One patient needed a short course of topical prednisolone. Otherwise, none of them needed topical or systemic prednisolone. And we were able to do procedures such as contact lens fitting, cataract surgery with these once the disease activity was quiescent. So this is the first patient in which I initiated systemic cyclosporin in my own practice. This patient has had cyclosporin for more than 3 years now, has undergone cataract surgery in both eyes, and is now on a lower dose of cyclosporin, which will ultimately be stopped. This 21-year-old has been on cyclosporin for more than a year. He had advanced glaucomatous damage and is now actually off cyclosporin. This lady with AKC, pseudoepitheliomatous hyperplasia, chronic cicatrizing conjunctivitis, is on tacrolimus and has now undergone cataract surgeries in both eyes, and the eyes are quiescent. So systemic therapy works. Apart from that, scleral lenses help. In VKC and AKC, one can do ocular surface reconstruction using Kletter SLET, as well as use Boston Type 1 K-Pro for these diseases. So the key messages I want to give is that ocular allergy can be chronic, it can be blinding. Please grade these cases by severity and periodicity. Systemic therapy may be actually vision saving in a selected cohort of patients. This allows us to do other procedures once the eye is quiet. And if one is to manage these very severe cases, it's important to have expertise in using these drugs, as well as have the availability of scleral contact lenses, ocular reconstruction techniques, as well as K-Pro surgery. Thank you very much for the opportunity to speak.
Thank you, Dr. Jayesh, for an excellent talk and very comprehensive. And it is really the kind of situation that we face quite often. As you said, you know, they don't fall into that chronic, seasonal, perennial anymore. There's a lot of overlap in spectrum. So one question to you, if there are a lot of younger children who come with this very severe disease, and they may also have other systemic allergies, and if you don't want to start them on the systemic immunosuppression immediately, have you ever tried low dose pulse steroids, oral steroids, anything like that? Any experience?
I haven't personally, but Dr. Sayan Basu has been using that strategy for quite some time, and he's quite happy with it. But I have really not been hesitant to use immunosuppression in children, because cases with VKC and AKC are not like infants or toddlers. They tend to be slightly older children, and they have been over decades been receiving these drugs for renal transplants, for nephrotic syndrome, etc. So there's a proven safety profile there.
Yeah, I think what you're saying is very true, because that it is that very fear of using these systemic medications which leads to them overusing topical steroids and landing up in the sight-threatening complications of glaucoma or others. So yeah, that awareness that when required, they are the lesser evil, so to speak. So we'd still be saving that child, and well monitored, they usually do very well. Thank you. Any comments from any of the other panelists? Otherwise, we will move to our next speaker. I think we'll move to Dr. Jaya Gupta. So Dr. Jaya Gupta is also going to talk some very interesting talk today, and she finished her Cornea Fellowship from Shankar Nethralaya, Chennai. She was a senior research associate at RP Center, and also further worked as a medical officer at Venu Eye Institute and Research, New Delhi. She has multiple ophthalmic interests and vast experience in various kinds of corneal surgeries, including lamellar keratoplasties, and work across different conditions, including neuro-ophthalmology. Multiple publications. She's been a speaker at conferences, and very, very dedicated clinician. And we thank you, Dr. Jaya, for joining us. Over to you.
Thank you, Sharon. I hope my screen is visible.
Yes.
Okay, so I'll be speaking on management of corneal perforation, the recent advances. It's more like an update and compiling the existing knowledge as of now. To begin with, the causes can be divided into infectious and non-infectious. The infectious could be bacterial, herpetic, fungal, parasitic. The non-infectious causes can be ocular surface related, like Sjogren's, vitamin A deficiency, mucous membrane pemphigoid, or the autoimmune causes like rheumatoid arthritis, SLE, Wegener's, inflammatory bowel disease, PUK, Murren's. And it could be traumatic, which can be both mechanical or chemical. So approach towards these cases would be eliciting a proper history and doing a proper corneal workup, which would include a Siegel's test, appropriate lab diagnosis, corneal scraping and drug sensitivity, and a systemic workup and appropriate medical consult and immunosuppressive dose adjustment. So the management essentially would comprise of non-surgical management, which is as vital as the surgical management. The non-surgical management would be antibiotics, cycloplegics, antivirals, antiglaucoma, doxycycline, vitamin C, topical steroids, cyclosporin, immunosuppressives, and the preservative-free artificial tears. Coming on to the surgical management, the different modalities available to us are corneal gluing. We can use the cyanoacrylate or the fibrin glue. BCL, RGP, surgical drape, I'll be describing them one by one. The Tennant's patch graft, the conjunctival flaps, amniotic membrane transplant, and then lastly, the corneal transplant, which could be patch graft or a Bowman membrane duct-in, stromal lenticule smile, lamellar keratoplasty, for example, tectonic DSEC or DSAEK or DSEC, tectonic epikeratoplasty, therapeutic keratoplasty, and off late, the bioengineered collagen-based fillers. So corneal gluing is the most, corneal gluing is the procedure which we most often resort to in these sedal positive microperforations, and they do extremely well. Perforations up to 2 to 3 millimeter, well managed with these cyanoacrylate glue, where the two methods, as we know, the drop and the disc method. Drop method in which a tuberculin syringe is loaded with the glue and a drop is placed on the perf, and in the disc method where circular punch, disc is punched out, and we apply the glue on the surface and then apply it for a smoother application after appropriate epithelial debridement and drying the surface. The different preparations available to us includes endermal, histoacryl glue, Nexacryl, Dermapond, Isodent, and Amcrylate. Glues with longer side chains are currently more widely used, less toxic, but they polymerize more slowly. They bond rapidly in an exothermic reaction, and polymerizes to form a hardened surface. So the glue prevents re-epithelialization into the zone of damaged stroma and hence inhibits polymorphonuclear leukocytes, which are the source of collagenolithic and proteolytic enzymes. They have antibacterial properties. However, they induce a lot of vascularization. The application surgical technique we've already discussed briefly. So it can be done in the slit lamp or in the operating microscope. The different, beyond the drop and the disc method, we can use a suture. We can make a suture meshwork and apply the glue on top of it. So another method described is using the tectonic drape patch. In this particular case, which had been done the conventional glue BCL, but it was not responding. So a sterile plastic drape that was in the surgical field was fashioned into 2 millimeter diameter patch, and the peripheral edge of the tectonic drape patch was glued over the perforation. And this is a histopathology picture of the same patient who underwent a PK. We can see that the drape and the perforation, there was no inflammation which was actually seen. The next is the fibrin adhesives, which most commonly we have the TISIL and the Relisil, which has got two components, the fibrinogen, aprotinin, and the second is the thrombin calcium chloride, which when mixed, they form a clear gelatinous fibrin clot. When pooled, human fibrinogen, plasminogen, fibronectin, and factor 13 in bovine aprotinin solution is combined with human fibrin, initiating the fibrin coagulation cascade. Once mixed, the fibrinogen cleaves fibrinogen into fibrin, then factor 13 cross-links the fibrin to form a fibrin clot. Both fibrin and fibronectin are able to cross-link with tissue collagen to adhere to the clot to surfaces such as corneal stroma. The bovine aprotinin acts as a fibrinolysis inhibitor to resist degradation of the clot. Now, both human fibrin as well as the cyanoacrylate glue are equally effective in closing perforations up to 2 millimeter in diameter. However, perforations larger than 2 millimeter, the cyanoacrylate glue is better. Human fibrin adhesive treated patients develop less GPC and deep stromal vascularization compared to cyanoacrylate glue. The disadvantages include faster degradation, they have no bacteriostatic effects, and the risk of transmission of prion and viral diseases. So there's another paper on this technique, which is called as epi-gluing, which came from RP Center. So the authors over here argued that instead of using something non-biocompatible like a surgical drape, they've used the patient's own epithelial cells for making for applying the glue. What they have done in this technique is that beyond the area of melt, 2 millimeter away from that, a part of the epithelium, 2 millimeter in size approximately, is delaminated with alcohol, and then this complex is transferred to the area of melt, and a drop of glue is placed on top of it. So here we can see in the ASOCT picture. Beyond this, the other techniques would be conjunctival flaps and amniotic membrane transplant. So conjunctival flaps would be superior pharyngeal conjunctival advancement pedicels like Gunderson's and C's Racket flaps. And they are good for indolent non-healing ulcers, impending perforation. They promote vascularization quite a lot. And the trophic factors, they provide trophic factors, mechanical protection and analgesic effects for better healing. The amniotic membrane transplant, again, it aids epithelial healing, promotes differentiation, migration of epithelial cells. Inhibitory proteases released by amniotic membrane induce apoptosis of local inflammatory cells, reducing the risk of corneal melt. And in a paper by Rodriguez et al., it showed 100% healing in microperforations, microperforations, and 25% closure up to 1.5 millimeter defects. With fibrin glue up to 3 millimeter in size, with fibrin, when used along with fibrin glue, it was effective in sealing perforations up to 3 millimeter in size. And when done multi-layered, it was effective in even sealing perforations beyond 3 millimeter in size. So my next case would be the next scenario, the next thing that I would like to discuss would be with a case example. Now this is a corneal perforation in which I had twice done glue BCL, but it was not working. Then I resorted to Tennant's patch graft, where this is on the first post-operative day, where we see the Tennant's patch, fluffy edematous Tennant's patch graft along with the sutures. And this is 2 or 3 days later. And this is the ASOCT picture where we see the Tennant's is well incorporated into the perf. And this is a few months later, where the fluffy edematous graft is now has almost shriveled up, and we can see the graft. And this is following this suture removal, where we see a nice scar and the patient improving to 6/9 vision. So Tennant's patch graft, tissue adhesive basically does not add volume to the site of perforation and is ineffectual in managing large or peripherally located perforations. This method is inexpensive, easily accessible, is effective in sealing large perforations up to 6 millimeter in diameter. The Tennant's patch harbors autologous fibroblasts that aid in incorporation into the host cornea without extensive scarring. The Tennant's capsule begins 2 millimeter posterior to the limbus, so we have to make the incision there. It comprises of 2 parts, the anterior thick fibrous tissue with smooth muscle fiber and fibroblast, and the posterior thin fibrous capsule. So the original technique was described with cyanoacrylate glue. I have a picture to show that, following which the AC deformation. The later techniques came with the tuck-in 360-degree lamellar dissection around the site of the perforation and closing it with overlay sutures, keeping it secured with the overlay sutures even if there was no glue. So the fluffy, like we saw in the case that I described, the fluffy edematous TPG in the early post-operative period transitions into a hyper-reflective, thin, compact graft over 3 to 4 months. So this was in this paper by Cora, where they actually dipped, after placing the Tennant's graft, the edge of the graft all around, just a drop of the glue was placed, securing it well. This is another photographic montage which shows how to measure the size of the defect. You take 1 millimeter oversize to it, and after excising and then doing a crescentic lamellar dissection all around, the graft was tucked in, and we can also suture it this way with interrupted sutures. The first author, Cora et al., reported 75% success rate with this technique. So another way of sealing the perforations would be a tectonic test with stripping endothelial keratoplasty in the management of corneal perforation. In this particular paper, there were 4 cases of exposure keratopathy, corneal hydrop secondary to pellucid marginal degeneration, and herpetic keratitis, in which 3 was DSEC and 1 was hemi-DSEC. Stripping was not done, but all the cases had also undergone a glue patch along with tarsography, and the minimum follow-up in this particular series was 4 months. So here we can see a well-adhered graft, but it failed to epithelize on the surface, for which again a glue patch was done. And this was a case of PMD where there was a aqueous leak, and after the hemi-DSEC, it cleared very well. So tissue, these particular authors, they say that the tissue adhesive success rate can be 44 to 86%. Corneal grafts require 20% repeat transplant for recurrence of infection and high graft rejection. So authors here have said that tectonic DSEC would avoid a GA, shorter surgical time and post-op recovery, avoid suture-related problems, and reduce rejection rates. DSEC provides creation of a tectonic scaffold to allow re-epithelialization while also allowing potential for visual recovery. However, this would be a challenging procedure in cases of perforation. Another method described is the Bowman membrane.
Dr. Jaya, I'm sorry, can you summarize?
Okay, so I'll just quickly, so the Bowman's membrane transplant, where the Bowman's membrane after harvesting, it is just tucked into the stromal pocket. We've used they've also, authors have described using the SMILE lenticule, where the SMILE lenticule is sutured along with the overlay amniotic membrane. And then corneal transplants, beyond everything else, like I'll quickly come over to these collagen-based fillers. So the collagen-based fillers is alternatives to cyanoacrylate for the sealing of large corneal perforations. These are basically placed, like this is an experimental study where the collagen is placed inside, and this is the collagen-like peptide which is linked to the polyethylene glycol, which is placed from above. So it seals it properly. These were experimental studies in which it was shown that with the cyanoacrylate glue, there was leak, whereas just the collagen hydrogels, there was a bulge, but when it was coupled along with the CLP PEG molecule, then it's sealed properly. However, this is structurally weak, difficult manipulation, and it's not in clinical use. So with this, I'll end. These are some future ocular devices, ocular adhesives, biodendrimer compounds. I'll not go into details of this. So that's the end. Thank you.
Thank you, Dr. Jaya. It was, it's a very long topic, I know, very massive to try and cover something like corneal perforations in 10 minutes, but you did a beautiful job and a lot of take-home points for all our viewers. So while Dr. Nidhi is setting up, just a quick question for you. When you do the Tenon's patch graft, the suturing you do is not our usual interrupted suturing, no. Right? It's across. Yeah.
Across. That's right.
Yeah.
But
any particular reason?
No particular reason, because I've just tried to follow what Dr. Sain Basu has taught. But later on, I saw the papers from RPC where Dr. Praful Maharana, he's taken interrupted sutures all along.
Both work.
And earlier I've tried the TPG with the cyanoacrylate glue, but that had not worked. But the overlay sutures without any glue has worked very well for me.
Thank you. We move on to our next speaker for this evening, Dr. Nidhi Gupta, a very dynamic clinician who will be speaking to us about DMEC. So Dr. Nidhi has completed her fellowship from Shankar Nethralaya, Chennai, and she also did a fellowship and worked with Dr. Virendra Sangwan on limbal stem cell work from LV Prasad Eye Institute. She is currently a consultant at Dr. Shroff Charity Eye Hospital in Delhi. And we welcome you, Dr. Nidhi Gupta. Mute. You're mute.
Dr. Nidhi, looks like you are on mute. Could you please unmute your lines?
I'm sorry, I think you can see my screen now.
Yeah, and we can hear
I
you.
think, yeah, I'm really sorry. I think I could not find my cursor, and hope you can see it now.
Yeah, now it's
Yes,
fine.
yes.
Thanks, Sharon, and thanks, Dos, for the invite. I'll quickly start my presentation because of the time that we have in hand. So I'll be talking about DSEC to DMEC. I think that's the topic for the day, upward slope or slippery slide. Sharon has given me that topic. I would not be going on to the surgical steps. What I would be talking about that, why are we evolving into surgery from DSEC to DMEC, from PK to DSEC and DMEC? What are the challenges which we see in adopting this DMEC, and how we can, deal with these challenges to go for a smoother transition? So when we see the evolution of a corneal transplant, I think it's a pursuit for a better vision, lesser rejections, and better long-term survival. And it is all based on using of less and less stromal tissue, which is responsible for more of rejections. And as we'll see in my presentation, how does it affect the vision? So if you look at the Indian scenario, so over the years from the papers that we have, which have indicated upon the indications of transplant in India, about 40 to 50% of the transplant are for indications like pseudophakic bullous keratopathy, Fuchs dystrophy, and failed grafts, which involved the endothelial disorders which result in on the corneal decompensation. So what are we doing for that? If we are transitioning from PK to DSEC to DMEC, we are reducing the interphase haze and the irregularity, as you can see on the ASOCT as well as the electronic microscopic pictures. So what you are trying to do is to reach more of what the anatomical outcome would be better in these patients, the amount of stroma you would reduce. Also, if you will see the transition of this use of lesser stroma into the visual outcome of these patients, then DMEC definitely has an early rapid visual gain. Not only an early rapid visual gain, but also subsequently the visual gain, the curve goes up even on the long term, as well as this results in lesser abrasions in these patients as compared to DSEC. Even the best of the DSEC in the form of the ultra thin DSEC has lesser visual gain as compared to patients with DMEC. So in DMEC, there is a norm. We usually have this mindset that maybe the DMEC would have a more of endothelial cell loss. However, if you see on the long-term follow-up, DMEC and DSEC have almost an equal cell loss over a period of time, and DSEC has no less than DMEC. When we go ahead to see the number of rejection rates, there is a lot of difference over a period of papers that you see on long-term follow-up. Some papers are now 3-4 years of follow-up. The rejection rates are far lesser as compared to DSEC. That's almost like DMEC has 1% to 2%, and DSEC is about 8 to 12%. And definitely PK has got about 20% of rejection rates. So DMEC, to concise, to say it in summary, has lesser rejection rates, better long-term survival. So that would convert into lesser use of steroids and secondary glaucoma in these patients. So what do we do as learners? I mean, there are a lot of mind blocks that we have, including myself. I had some mind blocks that maybe DMEC is far difficult surgery. If you see, it's a far thinner graft. And it's that you're going to waste a lot of tissue when you're trying to prepare the tissue. Is visibility a problem in Indian scenario because you have PBK as the main indications? And how do we finally learn if you say if it's better? So I'll be trying to answer those questions by just saying, if you look at the papers which have tried to study the learning curve for DSEC versus the DMEC, it's quite the same. So any person who's learning DSEC has a similar visual outcome to the patients as compared to patients in which we are trying to learn DMEC. Also, any surgeon doing DSEC would have a lot of steps are similar, and a lot of physics that works inside these surgeries is very similar. So you're going to have an easier transition to DMEC. Also, what is going to work when you're trying to learn is to do a wet lab course, to have a mentor around it. And definitely I'll be talking about the digital platform on which I'm working extensively. So to say over here, one word of caution, I would just say that definitely you need to shift to DMEC from DSEC, but you have to be wise enough to choose your cases. The DMEC indications are mainly a PBK in which you have a well-placed, nice IOL, you have minimum areas of peripheral anterior synechiae, and you have a good visibility. However, DSEC has an edge above, has its own place in cases which are more complicated, where there's an irregular anterior chamber, poorly placed IOL, shallow anterior chamber, and PAS. So the three major challenges in the learning curve that we have are the graft preparation, are the stages of graft orientation, learning the orientation inside the eye, and also that post-operatively you would see a larger number of graft attachments as compared to in patients of DSEC, and a need to rebubble. These are the apprehensions that you have while you're trying to learn. But what comes in hand is that you would, if you compare DSEC versus DMEC, you would see that the instrumentation is far, far simpler in DMEC. It is a surgeon prepared graft, and about from 8 to 10 grafts, if you try to prepare by the 10th graft or DMEC, you have quite specialized to have no tears or in the DMEC graft as well. So it's a matter of learning those 8 to 10 grafts. Also, with advent of time, with we going more advanced in the DMEC surgery worldwide, you are getting preloaded DMEC tissue as well in the West. And also, I think over time in India also, preloaded DMEC tissue is going to be just like an IOL, which will come in a cartridge, and you go and inject into the eye, in the eyes which are ideal for DMEC. If you will see also the visibility, which is one of the issues, you have techniques to actually go and do DMEC in patients with poor visibility, definitely, and having an OCT mounted onto your operating microscope would be best. However, you can use certain illumination techniques to actually see your DMEC graft and choose your patients correctly, which is going to help you to start DMEC. So with those, I would just like to say that as the world is moving from DSEC to DMEC, I think it's time we in India also start doing more of DMEC. To summarize with this, I would just like to say that it's mandatory to transition from PK to DSEC and DMEC in the right indications for the best outcomes in your patients. The learning curve can be shortened by being a part of a lot of wet lab sessions, having a mentor by your side in your early cases, to choose the right cases, to take you out from difficult situations, and to know what were the issues when you went wrong in your cases. That's going to really work a really long way, especially in DMEC, and also being part of the learning platforms. Also with time, there is a lot of standardization of the surgical technique which is happening. Earlier, DMEC was more experimental. You had a lot of various methods which were being followed, but with time, I think what works right and what works best with time is coming up in more defined ways, more defined techniques are coming up. That is going to help our learners. With which I'll also invite everyone who's attending and hearing me to the Global Summit on the group, which is working with me, mentored by Dr. Praveen and 5 of us core members working on the Global Summit, in which we will also be trying to bring a wet lab session for the learners. We'll be talking about the animal and the human models extensively for specifically the learners in the early stage to transition to DSEC as well as DMEC. Thank you for this talk and for the time. Any question? Thanks, Sharon.
Thank you, Nidhi. I think it's a lovely talk, and it's spoken from true experience. Your prowess in this surgery really shows when you talk about it. And yes, you brought out the fears of, a lot of us who are transitioning, when we are doing those cases. Case selection is so important in the early ones. Otherwise, you burn your fingers and then never want to go back. So I thank everyone for their wonderful talks. And Dr. Geeta is here who will, speak.
Thank you, Sharon. I think with that, we come to the end of this wonderful session. Congratulations to all the speakers for such splendid talks, highlighting your experiences, bringing out the nuances, so many take-home messages for all of us. And thank you, Sharon, for an excellent moderation. And a big thanks to DOS once again. CSI was glad to have been part of this venture. Thank you. Thank you, everybody. Thanks to the audience too. Thank you.
Thank you, madam.
Thank you.
Wonderful. Very fantastic and insightful discussions by all our speakers, and very well moderated by Dr. Sharon and Dr. Jaya. And a huge thank you to all our chairpersons for chairing the session, and Dr. Geeta as well. So before closing off with this session, I would like to take this opportunity to thank each and every one of us present out here, And since we are a one big happy family, I would request all of us to please turn on the cameras and unmute your line so that we can give a huge round of applause to all of us present over here. Maybe let's give a huge round of applause to all of us. Awesome. All right. So we are almost on time, 4 minutes overdue, but that's okay. The next session in this hall starts at 7:30 p.m. sharp. And the topic of that session is Nepal Ophthalmic Society session. So we'll meet you at 7:30 p.m. sharp again. Till then, this is me, Diksha Rana, signing off. Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Hello. Good evening, ma'am. Hello.
Hello.
Yes, ma'am.
Hello. Am I audible?
Yes, ma'am. मैम सर जो अटेंडी में है उनको भी बोल दीजिए, आप एक्सेप्ट कर लेंगे रिक्वेस्ट, लिस्ट में आ जाएंगे.
Pardon me?
समझ रहे हैं.
Hello.
Yes.
Professor Gyanendra, please accept the request. You are an attendee. We are promoting you to panelist. If you can listen. Hello. Hello.
Yes.
I have accepted as attendee.
Hi, everyone. Good evening.
Good
Thank you
evening.
for joining in. Thank you, Dr. Malla, for joining in.
You're welcome. Thank you very much.
Okay.
So, sir, we'll be starting off with the next session at 7:30 p.m. sharp.
Nepali time. Okay.
Hello, is it Nepali time or Indian time?
It's India time.
So that means 7:45 hour Nepali time.
7:45 hour time. That's
So,
what I get.
Okay,
So
okay, thank you.
Yeah.
Sure.
Thank you.
Hi, everyone. In case we have everybody who has joined in, we can start off at 7:30 p.m. Nepali time. That is fine.
Better.
Sure, sir. So we still have 8 minutes to go.
Is this Dr. Priya?
Yes, Dr. Malla, we have Dr. Priya online, but I think
see.
she's on mute here.
I see. Okay.
Hello? Hello? Hello?
Hello, Dr. Priya.
Hi,
Hello,
Dr.
hi.
Priya, we can hear you.
Yeah, so the thing is, it's written 7:30 Indian time, right? So everyone will be coming at 7:45. So our speakers and the chairperson, co-chairperson, I think they have been informed as 7:45 in the mail that was sent. So can we start at that time, or do we need to be here by 7:30?
Sure, not an issue. Let me
Okay.
check with the internal team once, and I'll get
Yeah.
back to you.
Okay.
Allow me a moment here.
Okay, thank you.
Sorry.
Hi, everyone. I'm checking with the internal team on the timings part. They are yet to confirm, so allow me some time, please. Hi, everyone. I've got a confirmation from the team on starting the session. However, I don't see Dr. Sanjay Kumar Singh and Dr. Srijana Adhikari on the call. So maybe we'll wait for 2 more minutes for them to join and then we can get started.
Hello, can you hear me?
Yes, sir.
Yeah. Dr. Sanjay Kumar Singh is not joining as he's sick right now. Dr. Srijana Adhikari will be joined soon. I'll try to make connect.
Surely, sir.
Thank you very much.
So once she joins in, we'll start off with the session.
Right. We have still a few more minutes here, 15 minutes. I'm right.
Yes, sir. So we are starting as per the Nepali time zone.
Oh, really? Wow.
Yeah.
I thought it is an Indian time. Okay. Yeah. Hello.
Hello.
So, Rohit, is it going to be Nepali time now?
Yes, sir. She said it's going to be Nepali time, sir. We have to start now.
Yeah. Okay.
Dr. Srijana is there.
Make sure all the panelists are there.
Dr. Srijana, are you there?
They started
Hello?
recording.
को बोल्नु भयो होला ए डाक्टर सबिना ल तपाईको स्ट्यान्ड बाई रेडी भएर बस्नु
ल दिदी अनलाइन आउनुस् न त्यो उसमा यो नेपाली टाइम रहेछ 7:30 चाँडै आइहाल्नुस् मैले सृजना दिदीलाई खबर गरेँ आउँदै हुनुहुन्छ
Hello, am I audible? Hello?
Loud and clear.
Audible.
Thank you.
Hello. Hi, Diksha.
Yes, sir. I can
Hi.
hear you. Yes, sir.
I think Dr. Priya is here, our moderator. So if it is going by Nepali time, shall we start right now?
Sure, sir. However, I don't see Dr. Srijana Adhikari.
He's still not here.
Do we have a...
There is a bit confusing. We also thought that it is Indian time. That's why you put the 15 minutes as a grace.
Okay. So I just got a suggestion from the team that it would be better if we start with the Nepali time zone. However, if it is getting confusing, we can start off with the India Standard Time. That is fine. Both are fine. So whatever suits you all.
Anyway, Dr. Ruit.
Sir. Yes, sir.
Let's have all the panelists there at least,
Yeah. We'll wait Dr. Srijana because she's a panelist there.
Yeah.
Surely.
Yeah. Maybe another couple of minutes.
Sure.
Yeah.
So according to Nepali times, it's going to be 7:45 to 9:15.
Yeah.
Okay.
No, according to that is Indian time, sir. 7:40 to 9:15 Indian time.
Since we are following the Indian time, no? Now that we are starting at 7:45 means.
Yes, he has given liberty to start whichever suitable for us.
No,
Yeah,
anyway,
once Dr. Srijana joined, we'll start, I think.
Oh, yeah, sure.
We have informed Dr. Srijana she is going to join soon.
Okay.
Perfect. I'm sure everyone is waiting for the Sunday dinners eagerly.
Really? Yeah.
Great. Okay.
We are working today.
Srijana
In Nepal, it is a working day.
Ah.
join हुनुहुँदै हुन्छ
Yeah. How is the rest of the sessions going on, Diksha?
त्यसो म अर्को लिंक
Sessions were good, sir.
Okay.
Very detailed, descriptive, and insightful.
Yeah.
Yeah.
Purushottam there?
True, sir.
No, Purushottam, thank you very much for fixing up your Zoom cloud meeting. Good.
Dr. Sabina also not there. I have sent the link.
She should be here anytime, I believe.
Hi, Diksha, can you send the link for Dr. Sabina Shrestha?
हुन्छ sir.
Sure, sir.
I have sent, but I didn't.
Sure, sir.
No, yeah, thank you.
AV team, could you please share the link to Dr. Sabina?
Yes, what
हेलो सृजना दिदी मैले त्यो फाइबरमा लिंक पठाएको छु त्यसबाट हुन्छ दिदी आउने बित्तिकै सुरु गर्ने भनेको छ
कोरिरहेको छु भन्नु
हजुर सर
सबैजना कोरिरहेको छु भन्नु
दिदी आउने बित्तिकै सुरु गर्छौं भन्ने
दिदीको इन्तजार मैले सरलाई देखिन हो
कसलाई
हजुरलाई देखिन ए देखे सर
Sir, I must be there.
Yeah, sir.
Video, sir.
हाम्रो कोठाको बत्ती मिल्दै नमिल्ने के हो सर यो बत्ती बालेको पनि अनुहार अँध्यारो छ हजुरको पनि त्यस्तै
No, right. We didn't discuss the timing yesterday, in our trial.
No, usually all the Indian webinars we participate as per Indian times.
Right.
That's why we thought that this is the Indian time.
Your this conference is hybrid, right? So, it's both physical and virtual, I believe.
Oh, sir.
And what is the Namrata in this DOS, man? What is she? Because she's joint secretary of the All India Ophthalmology Society. But is she the president of this Delhi Ophthalmological Society? Any idea?
She's secretary, sir.
She's secretary. No, she's secretary for AIOS. All India Ophthalmology Society.
Oh, DOS ma pani ho, sir.
DOS ko pani acha.
DOS ko president is Dr. Subhash Dadeya.
Dadeya.
She's the secretary. Yeah.
It's not cornea boy. It's not pediatric ophthalmologist. Subhash Dadeya.
I see. Now they have got north, south, east, west, central ophthalmological society of the whole country. Isn't it? They have got so many societies besides subspecialties.
Yes, sir. Big countries, many societies.
Many societies.
Yeah.
त्यो खुल्छ त त्यही लिंक पठाएको मैले अरूलाई पनि त्यसैबाट खुल्यो ओके मलाई सरलाई
मलाई त त्यो the one you sent Zoom in the Viber ma.
Diksha, can I request you to send a link to Dr. Srijana Adhikari also?
Sure, sir.
Yeah, thank you very much. She is also looking for the link.
I see.
Dr. Priya ko background is very prominent, very nice.
Recording. Should I change it?
No, that's fine. Fantastic. It's very much soothing.
Hello.
Background.
Dr. Srijana has joined. I can see her in the attendees. Hi, Dr. Srijana. Thank you for joining.
Hello. Yes.
Great. So are we good to start?
Dr. Srijana is here with us.
Yes, I see
that's
Dr.
fine.
Srijana online. However, I'm not able to hear her. Dr. Srijana, can you hear me?
Yes, I can. Can you hear now?
Yes, I can hear you now. Yeah.
Your sound is a little bit dim. Can you make loud? Srijana, can you make loud?
I think Dr. Srijana has joined in through her mobile. And because the mobile is a bit far, the voice is blurred. Yeah. Ma'am, we cannot hear you.
Share.
Dr. Srijana, we are not able to hear you. I think there's something wrong with the speakers.
Hello, now can you hear me?
Yes, now we can hear you.
Okay.
Perfect. So we are at 7:28 IST time already, and I will quickly introduce the session and then hand over to our panelists. All right. A very good evening, ladies and gentlemen, and a very warm welcome to all of you. I'm your virtual host, Diksha Rena, and it's my pleasure and privilege to welcome each and every one of you to this eventful evening at 72nd Annual DOS International Hybrid Conference 2021 at Hall A. So ladies and gentlemen, starting off with the last session of the day on Nepal Ophthalmic Society session, I would like to invite our chairperson, Dr. Om Krishna Malla, our co-chairperson, Dr. Rohit Saiju, our moderator, Dr. Priya Bajgai, our panelists, Dr. Sanjay Kumar Singh, Dr. Srijana Adhikari, and Dr. Purushottam Joshi. To begin with the session, I would quickly hand over to Dr. Priya Bajgai. Over to you, ma'am.
Okay, thank you. A very good evening and a warm welcome to one and all of you. I'm Dr. Priya Bajgai, working at the Nepal Eye Hospital, and will be the moderator for the evening. We, the entire Nepalese Ophthalmic Society, are pleased to be a part of the Grand Academic Festival Week of the 72nd Annual DOS International Hybrid Conference. Today, we have various participants who are going to cover a wide range of topics in various fields of ophthalmology. Our session is a total duration of 90 minutes. Thus, I kindly request all the participants to adhere to the time so that we have enough room for discussion towards the end of our session. Now, without further ado, I would like to start the program with the introduction of our distinguished group of chair and co-chair for the event. So thus, we are lucky to have with us Professor O.K. Malla sir as a chairperson for this session. Sir has been working as a professor at KMC until recently and is currently an honorary professor. He has contributed immensely to the development of retina services in the country. He was also the scientific chairman of the first SARC conference held in Kathmandu in 1991. He is currently the president of the SARC Academy of Ophthalmology and is also a board member at the Nepal Eye Hospital. Similarly, as a co-chair, we have Dr. Rohit Saiju sir, who is a prominent oculofacial plastic and cataract surgeon in the country. In 2014, for his contributions in clinical services for the country, he was awarded at the Asia Pacific Academy of Ophthalmology in Tokyo. Similarly, recently in 2021 also, he received an award at APAO for Best Achievement Award. He's the current president of the Nepal Ophthalmic Society, a founder president of the Nepalese Society for Oculoplastic Surgeons, Vice President for Oculoplastic Society for South Asia and Asia Pacific Society for Ophthalmic Plastic and Reconstructive Surgery. Similarly, today we have a great set of expert panel for the session. Thus, I would like to welcome Dr. Srijana Adhikari and Dr. Purushottam Joshi sir. Dr. Srijana Adhikari ma'am, she's a prominent pediatric ophthalmologist and strabismologist working as a head of department at Tilganga Institute of Ophthalmology. She has been working in various national and international research collaboration projects and outreach activities. She's a recipient of the Miller's International Travel Award 2015 and APO CEF Research Grant in 2018. She's an international member of American Association of Pediatric Ophthalmology and Strabismus, a section editor in Nepalese Journal of Ophthalmology, and the editorial board member of the Sao Chronicle. Similarly, we have Dr. Purushottam Joshi sir, who is the medical director at the prestigious Mechi Eye Hospital and is the head of department Vitreoretina and Pediatric Ophthalmology and Strabismus. He is an editor of the Nepalese Journal of Ophthalmology, has been elected as a treasurer and the general secretary in the Nepalese Ophthalmic Society. He was actively involved in the RAB survey held in 2009 and 2019. Now, I would like to request our respected chairperson, Professor Dr. O.K. Malla sir, to kindly say a few words.
Thank you, Priya. You can hear me, right? Okay. Can you hear me, Priya?
Yes, sir. Loud and clear.
Oh, thank you very much. And thank you very much, Priya, for your introduction. Let me begin by saying a big thank you to Delhi Ophthalmological Society for inviting us to this hybrid conference of the 72nd Annual Delhi Ophthalmic Society International. And my sincere appreciation to Nepal Ophthalmic Society for accepting the invitation and organizing this scientific session. Many thanks to the President, Professor Rohit Saiju and his team. Also, I would like to express my gratitude to the experts in the panel, the moderator, and the speakers for their participation. The topics I can see selected are very pertinent and very timely and will help our practice to perfection. the updates and the discussion which will follow are going to be an enriching experiences, I'm sure. Lastly, I like once again to thank you one and all for your participation and making this session a grand success. Thank you. Over to you, Priya.
Thank you, sir. Similarly, now I would like to request Professor Dr. Rohit Sahu, sir, our co-chairperson, co-chair for the session, to kindly say a few words before we start with our session.
Thank you very much, Priya. Good evening, ladies and gentlemen. It's my pleasure to welcome all the participants today to our beautiful venue tonight for the Nepal Ophthalmic Society session of 72nd Delhi Ophthalmological Society International Conference 2021. And thank you all for joining us. I welcome all the eminent speakers, panelists, guests from Nepal, India, and other parts of the world, attending from different walk of the life. You all have come here to share your knowledge and vast experience with us. We are proud to announce that the platform has given by Delhi Ophthalmological Society Conference organizing team to Nepal Ophthalmic Society. I would be thankful to Professor Subhash Dadia and Professor Namrata Sharma for inviting us to be part of the event. There will be plenty of knowledge enhancing activities in form of discussions, opinion, and expertise thoughts in respective talks. Would like to cover every aspect of ophthalmology through this session, so topics have chosen from different subspecialties here. The main outcome of this conference is to come up with consensus in controversies in diagnosis and treatment in difficult cases. I hope this 90 minutes Nepal Ophthalmic Society session would help us to expand our mental horizon to make complex to simple practice in provision of quality service to our patient. I would like to thank and acknowledge all the delegates and support team who has worked hard to make this conference truly successful. And like it been in the last years, I wish everyone a successful and fruitful conference. Thank you.
Thank you, sir. Now I'd like to call upon our first speaker for the session, who needs no introduction at all, Dr. Anu Manandar. She's an associate professor at the National Academy of Medical Sciences and is the head of Department of Uveitis Department at the Tilganga Institute of Ophthalmology. She's also a MD coordinator of TIO and is a section editor of the Nepalese Journal of Ophthalmology. She's done a fellowship in uveitis from the reputable California Pacific Medical Center and the Francis Proctor Foundation, University of California, and Aravind Eye Hospital. Today, she's going to be speaking about the achievements in the understanding of Shapu in 2 different centuries. Over to you, ma'am.
Thank you, Priya. Thank you, Nepal Ophthalmology Society and DOS for giving this opportunity to speak on this important and interesting topic. Can I share my screen?
Sure, ma'am. Please go ahead.
Share a screen, ma'am.
I'm doing that. Oh. Is my slide visible?
No.
No?
Not
okay.
yet.
Not yet.
Yes.
Is it visible now?
Yes.
Yeah.
Okay.
Better.
So I can start now. So the topic of my presentation is achievement in the understanding of seasonal hyperacute panuveitis in 2 different centuries. So we will be discussing about the findings of Shapu in two different centuries. That means in 20th century and in the 21st century. So in the 20th century, there were many findings, many achievements. That is, the main achievement is the discovery of the outbreak. Then again, the naming of the naming of this disease as Shapu and seasonal endophthalmitis, and there were identification of the clinical features of this disease. There were various causes which were ruled out. Histopathological examination was done, moth study was done, trial of medications were done, and the end result of treatment was found to be phthisis bulbi. So I will go briefly into all these different topics. So the first outbreak, which was identified was in 1975 AD. Professor Upadhyay found a group of children from a school of Pokhara with similar kind of findings, which was reported by Professor O.K. Malla in a national seminar on blindness of prevention of blindness in 1978. This was the first report. And there were two different names given. One was seasonal hyperacute panuveitis, coined by Professor M.P. Upadhyay, and the second name given was seasonal endophthalmitis, and this was termed by Professor O.K. Malla, and he described this condition as sterile suppurative infection. And the clinical features were identified: the circumciliary congestion, hypopyon, fibrinous exudate in the antechamber, muddy iris, exudates filling the crypts of the iris, fibrinous membrane covering the pupil, retrolental white deposit giving leukocoria, hypotony, and absence of fundal glow were described by Upadhyay et al. And this all happened in one eye, never in both the eyes. Other achievements were that toxoplasma, toxocara were ruled out by ELISA test. Immunological test showed low level of interferon, low level of HSV and CMV antibody titer, and Aquist was negative for bacteria, fungus. Histopathological examination done showed chronic inflammatory cells, complete retinal degeneration. And Tussock moth and animal experiment were done, but it could not conclude that Tussock moth was the cause of this strange disease. Various treatment were tried. Out of those, subconjunctival injection, oral steroid, azathioprine, all were tried, but then with fruitless outcome. And the end result happened to be irreversible hypotony or phthisis bulbi. Now regarding so the summary of this previous century was hyperacute the Shapu happened to be hyperacute diffuse inflammation of one eye, occurred predominantly in children of Pokhara and adjoining area and Kaski districts. Outbreak in autumn occurred every alternate year, and leukocoria, white reflex in red eye, and severe hypotony with flat antechamber, which was termed as malignant hypotony, were the hallmark of the clinical features of Shapu. Parasites were ruled out. Phthisis bulbi was found to be the end result despite aggressive treatment with steroid and immunosuppressive medication. Now coming to the 21st century, we were able to find more about this strange disease. And the first thing we found out was about the demography. The children and adult ratio discovered. Children were found to be predominantly affected. They were affected around in every outbreak, about 2/3 of the patients happened to be children, and rest were adult. It was found to occur in districts other than Kaski, in other provinces of Nepal as well. Hilly area commonly were affected. The virus was also found out, and summer outbreak and sporadic cases were found in pre and post-outbreak season. And as previous reports alluded that it was present in only Nepal, but now there is a report from Bhutan about Shapu. There were 2 cases reported by Rai et al. And there are cases coming from India, which has presented to Tilganga Institute of Ophthalmology. And this is another new finding. In terms of seasonal variation, in the previous reports, there were reports of autumn outbreak only, but then now summer outbreak is also found out. Although autumn outbreak, in the autumn season, the outbreak is always larger, whereas in summer it is smaller. And the pattern has been so that in every autumn outbreak, the maximum number of cases will come in the September month. As this graph shows, there is out of 55 cases, 25 cases happen to come in the month of September. And this is this slide shows that the various parts of the country from where the Shapu cases have come. There are so many districts from where Shapu comes. As we know, the heart of the outbreak is always the Kaski district and the adjoining district in the province number 3, whereas province number 4 is the heart-hit area, whereas province 3, 1, and 2 are also affected, and out of those, 3 is also badly affected. Different outbreaks, not in all. And in terms of the ecological variation, we see that hilly area is more prominently affected, whereas mountainous and Tarai region are affected less. And we could now know the stages of disease, the early stage and late stage. Early stage, it is in the early stage, we can see that there's hypopyon, there is a fibrinous membrane over the pupil, and the B scan in cases where we are not able to see the fundus, evaluate the posterior segment, will show very inconspicuous presence of the echogenic shadow in the vitreous. Whereas in the late stage, we see leukocoria, and the B scan is significant with echogenic shadow covering the whole of the vitreous. And clinical, in the clinical features, we are able to identify clinical signs of early stage versus late stage of the disease, which I just discovered. The discovery of the hair follicle in the eye was also found. Identification of newer clinical findings like iris atrophy, corneal sensation, diminution of corneal sensation, shifting hypopyon, fundus picture, and vitreous consistence in color were also identified. We can see the hair follicle in the stroma of the cornea in this picture. We can see this greenish white reflex, which is a kind of leukocoria, not seen in all Shapu cases, but in some Shapu cases. It is not white, but then greenish white in color. And there are different kinds of vitreous tap color, which alludes to the, which indicates the stages of disease. If the color is clear, and then it will indicate that the outcome of the treatment might be good. Whereas if the color is purulent, if the color is straw or green, then the outcome is poor. This is the sample drawn from the vitreous, which shows greenish in color, and the outcome of this case is poor. And now another findings we got from the researchers is that the white moth is the most likely connected with the disease. This was informed by the entomologist, Dr. Bhaiya Khanal, and he identified Gazellina moth as the possible cause, and white moths are now proven as the strongest risk factor by one of the studies. And then microbiological studies showed that isolation of bacteria from vitreous was seen in less than 50% cases, and we could identify culture positive versus culture negative cases. And the samples were negative for herpes group of virus, and the isolation of Toctinovirus was significant from the vitreous of Charcot infected cases. This is the picture showing the culture positivity, and Strep pneumoniae was predominant. Staph aureus was less predominant, and in children it was predominantly Strep pneumoniae, whereas in adult it was 100% Staph aureus. This is the slide showing the Toctinovirus presence. It was predominantly in the Charcot cases, whereas in infective cases it was less, and endophthalmitis case it was moderate. These are 3 types of Toctinovirus present in the Charcot cases. So in terms of management, discovery of the good outcome of pars plana vitrectomy was reported by Benji et al. Excellent outcome of intravitreal antibiotic treatment was found as a good, which leads to complete recovery of the vision in many cases. No additional benefit of intraviral antiviral treatment over antibiotic treatment alone was found out. Treatment protocol is now outlined. Oral steroid can be an additional treatment in some culture positive and culture negative cases. And treatment of outcome is now found to be like partial recovery of vision in 41% of cases. Globe can be saved in 1/4 of the cases. Phthisis bulbi occurs in 1/4 of cases. And there is difference in the culture positive and negative Charcot cases in terms of outcome. And other achievements are, like, we know that there are complications, other complications like iris discoloration, recurrent hyphema, corneal opacification, rhegmatogenous retinal detachment, optic atrophy with severe vascular attenuation, chronic hypotony, and phthisis bulbi. So these are some pictures showing iris atrophy in cases of Charcot. And this is optic atrophy in Charcot cases. Now coming to the summary of the findings of the 21st century, we now know that it occurs in other provinces other than province 3. It occurs in summer as well. Pathognomonic pathogenic viral cause has been ruled out, although presence of Toctinovirus could be marker of infection. Both and moth proved to be the strongest risk factor, and stages of disease is found out. Gram-positive bacteria is isolated from vitreous. Bacteremia and systemic bacterial infection has not been found. Intravitreal antibiotic for early stage is the best treatment, and intravitreal antibiotic and pars plana vitrectomy can give a better outcome in late stage. And oral steroid is not required in all cases, and it should be avoided before giving intravitreal antibiotic. Systemic antibiotic doesn't have any role. And this now seems to be the combination of ophthalmia nodosa and diffuse intraocular infection or endophthalmitis. The prognosis is found to be excellent in early presentation in case the prompt diagnosis is done and provided correct treatment is done, and the culture negative status gives good outcome. So now yet to be achieved is interrelationship moth, bacteria, and Charcot. Thank you for your attention. This is all I have for my presentation.
Thank you for the wonderful and interesting talk. Now I would like to call upon our next speaker, Dr. Gyanendra Lamichhane, who is Chief Medical Director and Head of Department at the Vitreoretina Services in the Lumbini Eye Institute and Research Center. He's currently a professor at National Academy of Medical Sciences. He has received various prestigious awards, and he'll be speaking on anterior uveitis today. So overall, on to you, sir.
Thank you, Priya. Am I audible and are my slides visible?
Yes, sir.
Okay. Good evening, one and all, and thank you, DOS and NOS, for giving me this opportunity. I am talking a very simple topic with the title anterior uveitis. Is it really so simple? These are my disclosure. So I'd like to start with one case. It is a 30-year male with decreased vision and mild red eyes, which was diagnosed as acute anterior uveitis with local practitioner and treated with topical steroid, but there is no improvement. And patient came to us, and on examination, we found that there is a sunset glow fundus with vitritis, and we do the further investigation. On OCT, we can find there is a sensory detachment along with the thickening of the choroid. Ultimately, it turned to the Voka-Nagy-Harada syndrome, and we started with the systemic steroid and azathioprine, and ultimately get improved. In second case is a 25-year immunocompetent male with history of blunt ocular trauma and red eyes, left eye redness and floaters. And the patient was diagnosed as a subconjunctival hemorrhage and traumatic mild anterior uveitis, and he started on a QID topical steroid. But still, there is no benefit to the patients. And on fundus examination of the posterior pole, it looks grossly normal. But for more detailed examination on the periphery, it showed there is some necrotic patches on the periphery, and ultimately it turned to the acute retinal necrosis, and it was managed with the systemic and the oral acyclovir. So where we can go wrong? The basic two things: we may go wrong during the diagnosis because we don't follow a systematic approach. We don't dilate every anterior uveitis patient in most of the time. And sometimes we don't bother to examine the another eye because the another eye has 6/6 vision, which ultimately lead to the mistake in management. So that's why anterior uveitis, it is not so simple what we think usually. If you see the usual history of anterior uveitis, most of the time the investigations are negative and non-infectious in etiology, and usually treated with a short course of steroid of 4 to 6 weeks with rapid tapering, lead to the recurrence and another course of steroid, and so the story continues on and on. And the end result is, after a few years, the patient will end up with lots of complications like band-shaped keratopathy, complicated cataract, cystoid macular edema, and ocular hypertony. So when we discuss about the anterior uveitis, we can get all these beautiful tables with a classification on the basis of anatomy, on the basis of duration and course, like sudden, insidious, limited, persistent, acute, recurrent, or chronic. And definitely we must have to grade the cells and flare according to the SON standard classification. And there may be the lots of etiology, which may be, some are infectious, maybe viral, some may be bacterial, some may be non-infectious, and some may be the autoimmune etiology. So what I usually, whenever I see in the slit lamp my anterior uveitis case, this is my own approach that I called is ALCAS approach. So what is this ALCAS approach? Whenever a case of anterior uveitis, first I ask myself whether it is true uveitis or it is a non-uveitis entity, such as pseudo-uveitis of pigment dispersion syndrome, pseudo-exfoliation, or there may be masquerades. Second one is, I like to see the location of the uveitis. If there is a predominant cell in anterior chamber and very few cells in vitreous, for me it's an anterior uveitis rather than intermediate uveitis. Third one, I like to see for if this fit into the any known anterior uveitis entities like Fuchs heterochromic uveitis and lens-induced uveitis, because these are the condition which is the spot diagnosis. We don't need any sort of investigation. And third one, I ask myself whether it is a purely anterior uveitis or part of pan uveitis. And final one is the looking for any systemic association. And once I'm sure that it is purely anterior uveitis, I try to find out whether it is active or inactive. It guides me to treat or not to treat. The severity for the steroid frequency, granulomatous versus non-granulomatous, which gives me clue to the etiology. And KPs is very important for me for anterior uveitis. Its type, distribution, and shape, which tells me one step towards the diagnosis. And I'm more concerned about the intraocular pressure and interior uveitis, because most of the time viral anterior uveitis is with the raised IOP. So the slit lamp biomicroscopy, a good quality slit lamp biomicroscopy, is the most important tool for anterior uveitis, usually 20x40 magnification, and we see all these things: corneal status, KPs, and overview of implant organs like iris. And always think, whenever identifying clinical phenotype is very important. Always think of common causes. For example, if we see a fibrinous content in AC in young male, always think of HLA-B27. Similarly, corneal opacity and iris atrophy, think of viruses. If mottled fat capillaries and iris nodule, rule out TB and sarcoidosis. And if stellate capillaries and loss of iris pattern, think of suspect Fuchs uveitis. So these are the common table we all know. I'm not going to detail of it, but the most of the time granulomatous uveitis may be starting at the starting. It may be a non-granulomatous at onset. And nowadays there is a controversial debate that there is no need to be a mutton fat capit to become a granulomatous uveitis. Once the capit is there, some authority consider it to be a granulomatous uveitis. And coming to the investigation, don't investigate a case of uveitis aimlessly, because it is not a fishing expedition. And don't create a lab in this diagnostic challenge for yourself. For example, you encounter a case of anterior uveitis in 30-year-old male. There is no systemic complaint, and you send for ANCA and it comes positive, because it is told that association between small vessel vasculitis and uveitis in absence of clear systemic sign symptom, it doesn't make any sense. So if you are dealing with the non-granulomatous anterior uveitis, try to search for these rheumatological causes, especially rheumatoid R factor, anti-nuclear antibody. And if you are dealing with the granulomatous anterior uveitis, these are the common tests we usually perform. 1-2 test, which is positive or negative, gives us some guidance. HRCT, I usually prefer HRCT in compared to chest X-ray. Interferon gamma, it is not always necessary. If you have, you don't have access to interferon gamma, it's okay. 1-2 stage is more than enough. And serum angiotensin converting enzyme, lysozyme, all are these for sarcoidosis. And liver function test is also needed if you are planning for starting the immunomodulator therapy. So anterior uveitis always follows a systematic approach. Determine the predominant site of inflammation. Try to decode the clinical phenotype before going to the investigation. There is no harm in back and forth taking the history, and always look for the systemic sign. And management, there is no fixed regime for the management of the anterior uveitis, but it is told that always hit hard, then taper slowly after a substantial period. The basic strategy is, if it is a non-infective, then usually we go for anti-inflammatory and immunomodulator. And if it is an infective, we have to treat with the infection. And for anterior uveitis, topical steroid in most of the time is more than enough, and we hardly need the systemic steroid or immunomodulator. And so it is still that all that glitters is not gold, because if you see a case of hypopene uveitis in your clinic, there may be different scenario. Let's see 3 different scenario, all has hypopene uveitis. In scenario 1, the patient has hypopene uveitis, but severe fibrinous reaction, non-granulomatous type, history of low backache, alternating eye, recurrent attack. It's a clear-cut case of HLA-B27. All you need is the HLA-B27 and the X-ray SI joint. Similarly, in case 2, there is a hypopine uveitis, usually pan uveitis, mobile hypopene, recurrent oral and genital ulcer. So it is a Behçet's disease. What you need is HLA-B27 and good rheumatological consultation. And third one is the granulomatous uveitis with the history of hospitalization of big abscess in thigh. It is an endogenous endophthalmitis. So all you need is a vitreous biopsy and other sample. So whenever you are dealing with the pediatric anterior uveitis, be careful. Usually you can go for the short course of oral steroid, and as early as possible try to shift to immunomodulator therapy rather than for long-term steroid. Because if you are giving the long-term steroid, you are converting this beautiful child into such not good conditions. So coming to the answer, anterior uveitis, is it simple? If we follow a systematic approach, meticulous history, careful examination of both eyes and system, and tailor investigation, definitely anterior uveitis is very simple. So I'm just recalling the same slide. I'm not going to read it out. And I'm concluding my presentation with these things, that little thing in life matters. If you can't do the thing little right, you will never be able to do the big thing right. Thank you so much for your kind attention.
Thank you so much, Dr. Ganendra, sir. That was a very interesting talk. Now, I'd like to call upon Dr. Ruchija, who is a vitreoretina specialist working at the ASG hospital. And today she'll be presenting on wet ARMD, a common yet challenging disease we encounter, and what the new treatment modalities are being offered these days. So, Dr. Ruchija.
Yeah, thank you, Dr. Priya. And I would also like to thank Delhi Ophthalmic Society and Nepal Ophthalmic Society for this opportunity. And I would also like to apologize in advance because I do not have the best of my voice today, but I'll try to explain the little what I have understood, the newer treatment modalities that are being offered in the management of wet ARMD. So wet ARMD is the leading cause of blindness above 50 years of age worldwide. It is the third leading cause of blindness overall. With the increasing life expectancy, the projected prevalence looks scary, that is 288 million by 2040. The FDA-approved anti-VEGFs are pegaptanib, ranibizumab, aflibercept, and brolucizumab. Bevacizumab still continues to be used off-label. So there has been historic development in the management of wet AMD. Before 1980, there was no available care for this disease, whereas in between 1980 to 1990, thermal lasers were introduced. Early in 2000, submacular surgery and photodynamic therapy were introduced, and all these modalities did not really help in gaining visual acuity, but just to control the disease without much anatomic and visual success. But the introduction of anti-VEGF has been a game changer in managing this disease because from 2005, we have plenty of anti-VEGFs that has been introduced. So we'll just have a look at all these drugs one by one. So this picture that shows a large subretinal fibrosis extending in between the arcades and a large disciform scar and probably total loss of central vision. And this was the fate of wet AMD if not managed. But thanks to anti-VEGF, now we have a lot of options, and it does not really help us in achieving a good anatomical outcome, but also functional and visual outcome as well. So the available anti-VEGF agents are pegaptanib, that's an aptamer. It binds specifically only one VEGF-A isoform, and it was introduced in 2004. Since it does not bind all form of VEGF-A, it did not gain much popularity. The next is bevacizumab. It is an off-label drug, ideally designed for the management of colorectal carcinoma. It is monoclonal antibody that binds all VEGF-A isoforms and has gained popularity since 2005 in the terms of safety and efficacy as well. The next drug is ranibizumab. It is an antibody fragment. It also binds all VEGF-A isoforms with higher affinity than bevacizumab. It was introduced in the year 2006 and still continues to be very popular. The next drug is aflibercept. It is fusion protein. It binds VEGF-A with higher affinity than bevacizumab and ranibizumab. It also binds VEGF-B and platelet-induced growth factor. It was introduced in the year 2012 and is a popular drug again. And brolucizumab is the newer drug that is a baby form, which was introduced in 2019, and it is a single chain antibody. So these drugs are such defined that with the developments in terms of molecular weight are decreasing so that there is increased concentration of the drug to achieve maximum therapeutic effect. Now, the newer drugs like aflibercept and brolucizumab not only helps in decreasing central retinal thickness, but we can see it also claims in reducing the choroidal thickness as well. So what options do we have in managing wet AMD till date is monthly injections. It's been time tested now. The pros are that it is most effective. The Marina and Anchor showed good success with strict monthly dosing. The 7-Up demonstrated that after patients stopped monthly injections, there was significant regression of treatment effect. The cons is that it is expensive. Obviously, there is risk of endophthalmitis, and CAT study showed that there is increased geographic atrophy when the injections were taken monthly. The next one is as needed basis. So whenever there is a return of subretinal exudation, the injections was injected as needed. So the pro in this treatment regimen is that it is most economical. It is slightly inferior result compared to monthly dosing as per CAT study, Pronto and Harbor study. The cons can be that it also needs close follow-up. The delay in treatment can lead to permanent defect, and in between dry and wet periods, it can have deleterious effects as well. The next regimen is treat and extend, which is the most popular regimen over the retina specialists throughout the world. Treat and extend, what happens is we give 3 monthly injections and increase the dose of injection by every 2 weeks until a dry macula is achieved. The pros in this regimen is that it requires lesser follow-up and it is more economical, but practically it is really difficult to achieve. So this is a quite common scenario. We keep telling our patients that we give 3 monthly injections and then we watch the questions from the patient always remain the same. How many more injections? The answer again is the same, like, I don't know. So the eyesight still going to be poor. And even after 3 injections, we might have to tailor the treatment according to the need of the patient. The challenges with all these regimens are that the durability of currently available anti-VEGF agents average from 2 months to a range of 4 to 12 weeks. It requires frequent injections in the operating room to be most effective, which gives a burden on the patient, the families, and medical care provider. It is often under-treated even with monthly or bi-monthly dosing, and there can be variable response, like VEGF targeting alone may be incomplete or suboptimal. So the best thing would be to have a gene therapy, which has now moved from science fiction to science fact. Gene therapy has US FDA approval for spinal muscular atrophy and liver congenital amaurosis. So gene therapy is promising alternative to ongoing eye injections of the drugs. Gene therapy uses a viral vector as conduit for transferring genes that instruct the host cells to produce therapeutic proteins that bind VEGF. It also offers to the promise of long-term durable expression of anti-VEGF proteins after single administration. So there are 2 different methods that are under investigation right now. One is injecting the gene therapy underneath the retina in a surgical procedure, and the other injects it into the eye just like a routine anti-VEGF treatment. There are 4 different drug candidates under investigation for wet ARMD and 1 for dry ARMD. So AVA101 is adenoviral associated virus vector that is delivered via pars plana vitrectomy and subretinal injection. It produces SFLT1, a tyrosine kinase inhibitor that binds VEGF. The phase 2 data of 32 patients showed a wide distribution of outcomes, including a subset of patients who showed signs of encouraging activity. The median number of rescue injections using the protocol-specified regimen treatment was 2 in AVA 101 treated subjects compared with 4 in the control group. So next one is RGX-3114, which is again investigational AAV4 gene therapy. And it contains a transgene that leads to the production of anti-VEGF Fab protein that exhibits anti-VEGF activity similar to that of ranibizumab. So now we have brolucizumab, which is longer acting anti-VEGF drugs. This is humanized single-chain antibody of 26 kDa, which is smaller than that of ranibizumab and aflibercept, but has a very high affinity for VEGF. The molecular properties, including its small size, lead to a fast systemic clearance and ability to deliver a high molar content in 0.05 cc intravitreal injection volume. The multicenter phase 3 of Hawk and Harrier trial compared intravitreal aflibercept 2 mg to intravitreal brolucizumab 3 mg and 6 mg in more than 1,800 patients. Sorry. After 3 monthly dosing, loading doses, the 6 mg brolucizumab group made the primary endpoint of non-inferiority to aflibercept every 8 weeks, as measured by mean change in best corrected visual activity from baseline to week 48. In the Harrier and Hawk trial, 52% and 57% of patients, respectively, were maintained at a 12-week dosing interval after initial monthly loading doses through week 45, which looks very promising till date. So next drug in the pipeline is abicipar pegol.
Hello.
Then no screen coming.
Yeah, I think we're
Yeah,
connection is lost.
yeah, that's what I see.
Few seconds are left. Maybe we can move on to the next presentation.
Yes, please.
Okay, so now I'd like to call upon Dr. Sanjita, who's a lecturer at the prestigious Institute of Medicine, Maharajganj. Today she'll be speaking on a very important topic, the corneal collagen cross-linking for keratoconus. Over to you, Dr. Sanjita, please.
Thank you, Dr. Priya. And today I'd like to take this opportunity to thank Delhi Ophthalmic Society and Nepal Ophthalmic Society for giving me this chance to talk about corneal collagen cross-linking for keratoconus. I do not have any financial disclosures. So as we all know, corneal collagen cross-linking is a technique which helps to strengthen the cornea by creating additional chemical bonds with adjacent fibrils inside the corneal stroma by means of a highly localized photopolymerization using ultraviolet light and riboflavin as the photosensitizer. This technique was first conceived by Professor Theo Seiler and his team in 1998 in Dresden, Germany. And since 2003, we have seen a lot of publications. And by now, we are sure that it is the least invasive and only known technique which is effective in halting the progression of keratoconus. So how does this technique work? So when riboflavin absorbs the ultraviolet A light with a peak absorption of 370 nanometers wavelength, then it releases, it activates the oxygen in the corneal stroma and releasing the singlet oxygen and superoxide anions. This leads to intrastromal oxidative reactions, leading to chemical covalent bonds bridging the collagen fibrils. This process, so this is a diagrammatic picture on the top left-hand side where we can see the weaker and fewer bonds in the collagen in a keratoconic eye. And after the cross-linking procedure, we can see that the number of the cross-links have greatly increased, leading to strengthening of the cornea by as much as 300%. So we know we have got ample evidences that corneal cross-linking is a very effective procedure. But still, there are a lot of conundrums in treatment, starting right from the indication. When is the right time to cross-link? So initially, it was propagated that corneal cross-linking was effective for progressive keratoconus. But how do we define progression? The criteria itself is not standardized yet. Many publications use various criteria for progression, like Kmax value, increase in more than one diopter, increase in refractive error like myopia, astigmatism more than one diopter, steepening of the anterior or posterior corneal surface, and thinning of the pachymetry by more than 10 microns. But then again, we know that topography as well as refractive error in these keratoconic patients is highly variable. So it's quite difficult to diagnose progression in keratoconus in such cases. Another observation led us to diagnosing progression in female keratoconic patients while they were pregnant. So maybe this could be another potential indication for cross-linking even when there is no progression. And as we know, patients who are at higher risk of progression, those who have positive family history with siblings and parents with keratoconus, those patients with vernal keratoconjunctivitis, who are eye robbers, and those patients who are diagnosed with keratoconus at a young age, who we know have a more aggressive course during the diseases, need to be cross-linked earlier before we see actual progression. Now, another conundrum is the type of riboflavin. As we know, a lot of types of riboflavin are currently available in the market, and the standard riboflavin with dextran, 20% dextran, is the one we use most of the time. But it causes shrinking of the cornea, leading to unacceptable cross-linking in thin corneas. So another option is using 0.1% riboflavin with HPMC as a base, which does not lead to shrinking of the cornea. For thinner corneas, we have now options of hypotonic riboflavin, and for transepithelial procedures, we can also use a higher concentration of riboflavin, like 0.25%, with a permeation enhancer like benzyl alkonium chloride or some other molecule which enhances permeation. So right now we have got a lot of types of riboflavin in our hands, and we can use it for our individual patients depending upon the need to improve our efficacy of treatment. Now, another conundrum is the type of procedure that we would like to do, whether we would like to remove the epithelium going for transepithelium or for epithelium off procedures. The main disadvantage that we have noticed with transepithelial cross-linking is the unavailability of the riboflavin in the stroma, because it impedes the penetration of the riboflavin. Hence, permeation enhancers like EDTA, benzyl alkonium chloride, tetracaine, sodium iodide have been used, and recently iontophoresis has shown a lot of promise. Why do we want to use transepithelial technique? Because it is associated with less complications like corneal infections, haze, sterile infiltrates or reactivation of keratitis, and there is greatly reduced postoperative ocular discomfort and pain. However, the disadvantages are that there is less depth of treatment and the clinical results are quite variable. For example, in this study, which was published in Clinical Ophthalmology in 2020, they noted that the progression rate was quite high compared to the standard Dresden protocol. And the higher rate of progression was seen in patients who had higher Kmax, key mean, and D index values at the starting of cross-linking. So they suggested that in more advanced cases of keratoconus, maybe transepithelial cross-linking is not very effective. So maybe we have to go for Dresden protocol, a standard Dresden protocol, which has been effective, which could be more promising in these cases. The other conundrum is which procedure should we go for, the accelerated protocol or the standard protocol? So in the accelerated protocol, which was described by the Bunsen-Roscoe law, that the effect of the photochemical or photobiological reaction is directly proportional to the total irradiation dose, irrespective of the time span over which the dose is administered. So by giving a higher irradiance power, we can decrease the duration of time over which the energy can be delivered, but getting the same cross-linking effect. But considering that the UV radiation is the constant source, the oxygen and riboflavins availability need to be replenished all the time. So to tackle the problem of oxygen depletion, we can either use pulse ultraviolet radiation or oxygen goggles. So this was a recent study published in Cornea, which compared the efficacy and safety of standard versus accelerated cross-linking, and it was done by the SafeSight Keratoconus Registry. And this study observed that both the standard as well as the accelerated cross-linking were similarly safe and effective in stabilizing the cornea. So this finding supports the adoption of accelerated cross-linking for both time and convenience. So this result will help us greatly to move on from standard to accelerated cross-linking in most of our cases. Now the issue of syncornea. As we know, the traditional protocol has been not to cross-link corneas less than 400 microns, but what should we do for thinner corneas? So various protocols were developed. The hypoosmolar riboflavin cross-linking was developed by Professor Hafizi and his team in 2019. Later, Dr. Susan Jacob and her team described the contact lens-assisted cross-linking technique in 2014. And in the same year, the epithelial island technique was described by Mazzotta and his team. Recently, the sub-400 protocol by Professor Hafizi again is gaining a lot of popularity, and if it proves to be useful, will be very effective. In which we will vary the irradiance of the UV power and the time according to the corneal thickness, so that we get the demarcation line just 70 microns above the endothelium. So this is very exciting development in corneal cross-linking technique. So what does future hold for us? So maybe we could move it from the ORs to the slit lamp. So this device, the CI device, was designed to perform the cross-linking at the slit lamp. And let's see how effective it's going to be. So with this, I'd like to end my presentation. Thank you.
Thank you so much for that interesting talk. Now I'd like to call upon our next speaker, Dr. Anil Borajli, who is currently working as a glaucoma specialist at the Biratnagar Eye Hospital. He has a special interest in the pathogenesis of glaucoma and also aims to continue his further studies in expanding the understanding of the pathophysiology of glaucoma. So today he'll be speaking on glaucoma in myopia. Dr. Anil Borajli, kindly carry on.
Okay, am I audible?
Yes, you are.
Okay, thank you very much. First of all, I would like to thank the Delhi Ophthalmic Society and Nepal Ophthalmic Society and the Glaucoma Society of Nepal for allowing me with this opportunity. So today I'll be talking about glaucoma in myopia. So as we all know, cases of glaucoma in high myopes poses a diagnostic dilemma because of the atypical presentation of the optic nerve head in such cases, and also high myopes usually present with visual field defects that usually mimic glaucoma. So besides this, the other concern is that myopia is growing out to be a public health concern and is projected to affect 5 billion people globally by 2050. We all know myopia is an established risk factor for glaucoma. So as the cases of myopia increases, the prevalence of POAG2 is bound to increase. So once in a while, working as an ophthalmologist, we are bound to encounter such kind of high myopic optic nerve head, which will pose diagnostic challenge to us treating ophthalmologists, whether to treat the patient or whether to observe the patient. So whenever we encounter a young middle-aged high myope with such kind of optic nerve head presenting with visual field defect, but however the IOP remaining within the normal range, it is always challenging to determine whether the patient has truly glaucoma and requires any IOP lowering therapy. So whenever such patients come to us, deciding whether or not to treat is basically a trade-off between the risks of therapy versus the benefits of reducing the likelihood of irreversible progressive optic nerve damage. We should always remember, overtreatment is always a risk because of lifelong commitment is necessary, which can be costly, and one should always weigh the pros and cons of observing such kind of patients. Here I would like to start with a case study that was published in a peer-reviewed e-magazine by Dr. Chang from Byers Eye Institute of Stanford University. A 42-year-old woman with high myopia was referred for glaucoma consultation because of visual field abnormality in her left eye. She had normal IOP and normal CCT. As you can see, her left eye is grossly suspicious for glaucoma, and the visual field defect can be clearly seen in her left eye. Her right eye shows superior temporal and inferior temporal wedge defect, and the visual field is grossly depressed. So discussion regarding the pros and cons of surveillance with or without treatment was done with the patient, and the patient opted for treatment. Under medications and SLT in her left eye, the IOP did not decrease substantially in her eyes. But however, after 6 years, the patient didn't show any progression on her optic nerve head dysphoto, OCT, or the visual field, with the pressure remaining within the mid-teens. So what are the learnings from this case? We may never know whether or not the patient had glaucoma, but medical therapy, if well tolerated, is a reasonable approach to this case because of the visual field she had at the time of presentation. But we should remember, aggressive lowering of IOP to single digits, which often requires surgery, may not be the ideal strategy unless the patient has unusually rapid disease progression. As mentioned earlier, detecting glaucoma in a case of high myope is a clinical challenge. Here I am showing you pictures of two optic nerve heads of high myopic patient. The picture on to your left is a high myope with advanced glaucoma, whereas that on to your right is a high myope with no glaucoma. As you can see here in the picture to your left, the patient has a very thin neuroretinal rim as shown in between the long and short array, whereas the neuroretinal rim on the picture to your right is absolutely normal. So in this class, we'll be discussing the structural and functional assessment for detecting glaucoma in cases of myopic eyes, how these tests can be misinterpreted in a myopic eye, and the pathophysiology on how myopia might predispose towards glaucoma. So moving on to the clinical assessment, first I'll be talking about the OCT. First is the assessment of the neuroretinal rim. The technology that we use is the measurement of the BMO MRW, in which we measure the minimum distance between the Brooks membrane opening and the internal emitting membrane of the retina. However, the pitfall in cases of high myope is that the margin of the Brooks membrane may be indistinct, or it may move away from the temporal optic disc border, thus introducing errors. Next is the measurement of the INFL thickness. However, the pitfall might be that the superior temporal and the inferior temporal bundles usually tend to get together temporally. So this temporalization of the INFL bundle leads to abnormally thin out INFL superiorly and inferiorly. As shown in this OCT printout, we can see that this patient has a false positive INFL thinning in the INFL deviation map in the inferior temporal, both in the right eye as well as in the left eye. This is popularly known as the red disease in a case of high myope. Next is the assessment of the ganglion cell inner plexiform layer. However, in cases of high myopes, irregularities at the macular region may confound the DCPIL assessment. False positive thinning on the DCPIL deviation map is also more common because of the longer axial length. And besides, myopic macular degeneration can also play some confounding results. Next is the assessment of the INFL texture. This is a new technology that has been developed in the OCT, which is known as the ROTA, that is the retinal nerve fiber layer optical texture analysis. It studies the reflectance pattern rather than the thickness. The advantages of the ROTA over INFL measurement is that it does not rely on the comparison against the population-specific normative database. So it may be more suitable in cases of myopic eyes, but however, it is still in the developmental phase. Next is the assessment of the visual field. Few considerations has to be made. We have to clearly look at the pattern of the visual field loss. As we all know, in non-myopes, the only visual field usually starts at the germ area or as a nasal step and progressively increases upon the fixation, and the central vision is usually spared until late in the disease. Whereas in case of myopia, central or paracentral scotoma usually occur earlier due to the involvement of the papillomacular bundle. So now moving on to the pathogenesis of the disease, why a glaucomatous visual field damage occurs in cases of myopia. The exact mechanism is actually unknown. The theory is that the axial elongation leads to stretching and thinning of the lamina cribosa and the peripapillary scleral flange. This exposes the retinal ganglion axons to mechanical strain as they traverse the porous lamina cribosa down a pressure gradient. In addition, the optic nerve deformations such as the torsions and tilt might cause further damage. Thus, the visual field defect in cases of the myopic optic neuropathy may be more related to the mechanical stresses rather than to the elevated IOP. So studies have shown that myopic eyes showing progression usually have higher baseline IOP rather than those that didn't have progression. So this may suggest that the existing lamina cribosa defect might act as a focus of strain only when exposed to higher IOP. Thus, in cases of POAG, IOP and severity of myopia might have synergistic effect on the risks of the glaucoma. Thus, when the baseline IOP is low, myopia may not predispose towards further glaucomatous damage. So in support of this, I would like to talk about few cases that was published in the American Academy of Ophthalmology in 2007. This was a study done on the Chinese population. This case is a 42-year-old male, myope of -3.5 and -2.75 in his right and left eye. As we can clearly see, the patient has a superior arcuate defect in his left eye and a nasal step in his right eye. The patient had a normal IOP of 15 and 16 in his right and his left eye. And after 8 years, under no treatment, the patient's visual field and optic nerve didn't show any changes. So this patient is a 50-year-old male, a high myope with IOP of 14 under anti-glaucoma medications. As we can see, this patient has a superior arcuate defect in his left eye and a gross superior field defect in his right eye. So after 5 years of treatment, this patient too didn't show any progression. So the pathogenesis, or should I say the theory why these patients didn't progress, might be that, as we all know, glaucoma by definition is a progressive disease, especially not when adequately treated. But in case of myopic optic neuropathy, the myopia leads to temporal tilting of the optic nerve head. And this leads to inferotemporal and superiotemporal. This might make the inferotemporal and the superiotemporal INFL vulnerable, which mimics the glaucomatous axonal loss. But however, unlike glaucoma, the process usually slows or halts once the progressive thinning and tilting associated with the axial myopia abates. So I would like to just briefly highlight on the management of myopic optic neuropathy. In the setting of axial myopia and static visual field defects, these patients can be managed conservatively and limited if any use of ocular hypertensives. Filtration surgery is not usually indicated in such patients, given that these visual field defects usually fail to progress significantly over time. So finally, moving on to the conclusion, myopia, besides being a risk factor, complicates both the diagnosis and treatment. Myopic deformation and not the refractive error is related to worse visual field. Further research is needed to determine better ways to confirm a diagnosis of glaucoma in myopes without long periods of follow-up. With this, I would like to conclude my presentation. Thank you very much.
Thank you so much, Dr. Onion, for that very interesting talk. Now I'd like to call upon our next speaker, Professor Dr. Sabina Shrestha ma'am, who's a consultant pediatric ophthalmologist at the Kathmandu Medical College. She is a member of the Central Executive Committee of the Nepal Nitra Jyoti Sangh and is also a coordinator of the ICO exams in Nepal. She also has a sheer interest in arts and literature with a recently conducted solo painting exhibition. So today she'll be speaking on culture positive cases of ophthalmia neonatorum in Tertiary Eye Care Center of Nepal. Over to you, ma'am, please.
Thank you, Priya. Respected chair and co-chair, can you view my screen?
Yes, doctor, we can see your screen.
Can you see your screen?
Yes,
Yes, we can.
Yeah.
Okay, thank you. Ophthalmia neonatorum, although runs a benign course mostly, sometimes it may progress to sight-threatening complications. This study was conducted to find the causative of microorganism and the antibiotic sensitivity in cases of ophthalmia neonatorum. It was a descriptive hospital-based cross-sectional study done in Kathmandu Medical College, Sinamangal from January to December 2019. Newborns up to 28 days of life presenting to Department of Ophthalmology with watering or discharge from the eyes, with no other causes for the same were included. Less number of neonates presented who met the inclusion criteria. 25 participants were initially enrolled, but only 18 completed the study. History was taken from the parents and clinical examination was done. Conjunctival swab was sent for culture and sensitivity, and convenience sampling was done. Coming to the results, male to female ratio was 1:1. 50% of the babies were delivered normally, while 50% underwent cesarean section. Majority of the neonates, 94%, had bilateral involvement, and 55.6% presented within 48 hours. The discharge was purulent in 44%. Pseudomembrane was present in 5%, in 28% of the cases, and cornea was not involved in any of the cases. Culture of the conjunctival swab was positive in 56%, and the causative organisms were Coagulase negative, Staphylococcus 40%, Staphylococcus aureus 30%, Klebsiella 20%, and Pseudomonas 10%. This slide shows the overall antibiotic sensitivity of the microorganisms isolated. And out of the culture positive organisms, vancomycin was the most sensitive antibiotic, accounting for 70%, followed by ciprofloxacin, sensitivity was 60%, cloxacillin 50%, amikacin 50%. However, azithromycin, cotrimoxazole, and cefixime were the least sensitive ones. Coming to the discussion, in the present study, males and females were equally affected. However, most of the studies have shown that there is male preponderance. The male gender as a risk factor or increased neonatal infection has been attributed to Y gene. In a study by Hostel A et al., also, Staphylococcus species was the most common organism isolated, which accounted for 44.4%. Usually, the infectious organism contaminates the neonates through direct contact during passes through the birth canal. However, the infection is also known to reach the uterus, so that child delivered even by cesarean section can develop ophthalmia neonatorum. Even if so, that is also more in cases with prolonged rupture of the membrane at the time of delivery. In the present study also, 60% of the mothers with culture-positive babies for ophthalmia neonatorum had undergone cesarean section, while 40% had delivered normally. However, among the total participants, delivery of the babies was by a normal route, and cesarean section was equal in proportion. In a study by Hostel A et al., Staphylococcus species was the most common organism isolated, accounting for 44.4%, followed by Chlamydia trachomatis 13.6%, Streptococcus pneumoniae 13%, E. coli 9.9%, Enterobacter 7.4%, Klebsiella 3%, H. influenzae 1.8%, and Pseudomonas 1.2%. Similarly, in studies conducted by Limo E. and EBGJ, Staphylococcus aureus predominated as the cause of ophthalmia neonatal. Staph also accounted for most common causative organism also in study by Vincent N.J. et al. And by Sultan Zadin M.H. et al. Similarly, in a case control study also, the most common pathogen isolated was Staphylococcus, but it was found both in the cases and in the controls, which could be due to the fact that Staph aureus is one of the most common commensal of the eye. In the present study also, the most common organism isolated is Staphylococcus, followed by Klebsiella and Pseudomonas. And Streptococcus is isolated in none of the cases in the present study. So coming to the conclusion, culture of conjunctival swab was positive in more than half of the cases of ophthalmia neonatum, in which Staphylococcus species was the most common organism isolated from neonates. Vancomycin was the most sensitive antibiotic, which was sensitive against majority of the organisms detected. And culture sensitivity showed variable sensitivity of the drugs, even in case of the same organism which was isolated. So I would like to recommend that neonates presenting with signs of conjunctivitis should have the conjunctival swab sent for culture and sensitivity and treated accordingly. These are my references. Thank you for your kind attention. I think I completed before time.
Yes, ma'am. Thank you so much. Thank you for that interesting talk. Now I'd like to call upon Dr. Kavinder Bhattacharya, who is an associate professor, consultant pediatric ophthalmologist, and outreach director at the Lumbini Eye Institute and Research Center. He was the executive member of the Nepal Ophthalmic Society, and he's also a PhD scholar in Buddhism from Tuvan University, and is also a spiritual leader who engages on mass education and spiritual practice. So today he'll be speaking on experiences on a few vertical muscle surgeries. Over to you, Dr. Kavinder, please.
Thank you, Dr. Priya. Today, I'm talking on my experiences on a few vertical muscle surgeries. I have no financial conflicts of interest. So we are 3 pediatric ophthalmologists currently working in Lumbini Eye Institute and Research Center, Nepal. From January 2020 to September 2021, we had conducted 132 strabismus surgeries, and among them 18 were vertical strabismus, so comprising 13.63%. We had operated on infantile esotropia with inferior oblique overaction, and also inferior oblique overaction associated with partially accommodative esotropia, intermittent and alternate exotropia, and hypotropia associated with ptosis, double elevator palsy, and third knob palsy. So while we're talking about vertical muscles, especially we are performing inferior oblique, sometimes inferior rectus, and occasionally superior oblique and superior rectus muscle are being operated. Coming to infantile esotropia with inferior oblique overaction, this is commonly performed vertical muscles. Usually bilateral middle rectus recession is done with inferior oblique recession, sometimes myectomy plus minus myotomy according to the grade of inferior oblique overaction. We are following the chart given by Professor Kenneth Wright. So this is one child, 7 years female, presented with base corrected visual acuity 6/6 bodi infantile esotropia with more than 30 prism diopter of esotropia plus 3 overaction inferior oblique right and plus 1 over left eye. We did 6.5 bilateral middle rectus recession, and right eye 1 mm and left 3 mm posterior to inferior rectus temporal pole. And the post-op, the finding on the first day was residual +1 in right and left, almost it is normal. So this is one of the pictures showing inferior oblique recession. This is 5 years female who had partially accommodative esotropia, retinoscopy being +6 in right and 6.5 dyspheric on left. Prism cover test 30 with glass and 60 prism diopter without glass with both eye +3 inferior oblique overaction. So we can see here the accommodative, the partial accommodative esotropia. So in this patient, we performed bimedial recession 5 mm, and again inferior oblique recession 3 mm posterior to inferior rectus. And post-op, there was a small angle residual ET and with glass orthotropia. This is intermittent exotropia with 45 prism diopter and the inferior oblique overaction of +2 both eye. And here also we did bilateral recession of 8.5 mm and inferior oblique recession 3 mm posterior to inferior rectus, the temporal pole. And the post-op, first post-op picture showed the ortho and inferior oblique overaction is recovered. This is case of alternate exotropia with 40 prism diopter with inferior oblique overaction +3 right eye and left eye +2. Here again we did bilateral recession of 8.5 and inferior oblique 2 and 3 mm posterior to inferior rectus pole. And post-op picture, we can see the very good alignment. This is ptosis with hypotropia, where we did inferior rectus recession of 5 mm and superior rectus resection of 5 mm. And on very first post-op day, there was 10-degree residual hypotropia. This is 21 years female presented with double elevator palsy. Vision 612-66, -4 for right superior rectus and right inferior oblique. FDT was negative. Here we performed modified Nishida's procedure, which was explained by Dr. Soumya, and she presented on AIOS 2018. We did 4 mm recession of inferior rectus and middle rectus and lateral rectus 10 mm from insertion. 1/3 of superior muscles are sutured at sclera 12 mm posterior to limbus diagonally without splitting and no tenotomy, but transposition was done. And this is the picture showing the inferior rectus recession, and rest 2 pictures are superior middle and superior temporal with Ethibond 5/0 suture. The superior part of the muscle, superior middle and lateral rectus are sutured. So I have the small video here. This is inferior rectus recession we are doing here. And then this is superior rectus. This is lateral and medial rectus, which were 1/3 of the muscle were sutured superior temporally and superior nasally. This is also a picture of double elevator palsy with -4 left eye inferior oblique and superior rectus. So after we did Nishida's surgery, he had got a very good alignment in primary position with small angle of residual hypo. This is next case with Turner palsy. She had ptosis, exotropia, and hypotropia. In this case, we did inferior rectus recession of 5 mm and superior oblique tenotomy. And on the very first post-op, there was 15 prism diopter of residual hypo. And we planned for lateral rectus recession and the second eye surgery for exotropia later. So this is inferior rectus recession, and this is the superior oblique tenotomy. After that, hypotropia was very well controlled on the very first post-op there. So coming to the conclusion, so strabismus surgeons need to be familiar with the horizontal muscles first and then can move for vertical deviation surgeries. Though vertical muscle surgeries are not as simple as horizontal muscle surgeries, with the experiences, the surgical outcome is rewarding. Proper counseling to the patient is very important. So thank you everyone for listening me, Delhi Ophthalmic Society, Nepal Ophthalmic Society, and Nepal Pediatric Ophthalmology Society for allowing me for this presentation. Thank you all.
Thank you so much, Dr. Kavindra. Now we want to come to our last presenter, Dr. Ashish Rajpant, who's a consultant cataract and oculofacial plastic surgeon at the Meiji Eye Hospital. He's the executive member of the Nepalese Society for Oculoplastic Surgeons and a section editor at the Nepalese Journal of Ophthalmology. So today he'll be speaking on the comparison of outcomes of single approach surgeries versus combined surgery in involutional lower lid entropion. Over to you, Dr. Ashish, please.
Thank you, Dr. Priya. Am I audible?
Yes, you are.
The topic of my presentation today is comparison of outcomes of single approach surgeries, Wise and Jones procedure, and combined surgery, lateral tarsal strip with cricket suture in involutional lower lid entropion. I don't have any conflict of interest. And coming on to introduction, involutional lower lid entropion is the most common type of entropion resulting in the inversion of lower lid margin due to the senile changes in the lower eyelid structures. The mechanisms being horizontal lid laxity, that is degenerative changes in the lower lid support structures such as medial canthal tendon, lateral canthal tendon, and the tarsal plate. Vertical lid laxity, that is disinsertion or senile dehiscence of the lower eyelid retractor, capsulopalpebral fascia from its insertion, and overriding of the preseptal orbicularis oculi muscle into the pretarsal, which induces the inward movement of the lower eyelid margin. The surgery is the mainstay of the management of entropion, and lateral tarsal strip and wedge resection are some common methods to address the horizontal lid laxity. White's procedure and cricket sutures address the orbicularis oculi overriding, and Jones procedure address vertical lid laxity. However, we can also combine these surgeries, such as in cricket procedure, Wise or Jones with lateral tarsal strip and lateral tarsal strip with cricket sutures. Although numerous surgical techniques have been described in the literature, there are no consensus regarding the optimum management plan or surgery of choice. The one-size-fits-all approach might result in complication and high recurrences due to the varied underlying mechanisms. Thus, a flexible approach to the entropion surgery guided by the underlying mechanism is needed. However, there are no such protocols or guidelines in the literature, and furthermore, no studies have considered the management of entropion based on the horizontal lid laxity, vertical lid laxity, and preseptal overriding. The objective of this study was to compare the surgical success, complications, and recurrence rate of single approach surgeries with combined approach surgery in cases of involutional lower lid entropion with and without significant horizontal lid laxity. This was a hospital-based retrospective study comparing the outcomes of White's procedure, Jones procedure, and combined surgery. These are the inclusion and exclusion criteria. Only 3 of the commonest surgeries performed at our hospital was taken for the comparison. Other surgical methods were discarded due to their lower frequencies. And horizontal lid laxity amount was measured using the passive eyelid distraction test using the Surmus strip and was recorded. The horizontal lid laxity, if was between 0 to 6 mm, was termed as not significant, and if more than 6 mm, that is 7 mm or more, was termed as significant. This was in accordance with the study done by Ansari et al. This is a case of right eye lower lid entropion, and we can see the pinch test, that is passive distraction test. This is the Surmus strip, which has been, the rounded edge has been cut so as to measure the passive distraction or pinch test. And this is how we measure the amount of horizontal lid laxity based on the passive distraction. The standard technique of White's procedure was done. However, we modified it a little bit with thin stripping of the preseptal orbicularis, that is around 1 to 2 mm, which was preseptal orbicularis, and along with the overlying skin before closure. Similarly, in the Jones procedure, the standard technique was performed. However, a thin strip of preseptal orbicularis along with the overlying skin was removed. This is a picture showing the Jones technique, in which we can clearly identify the capsulopalpebral fascia or the inferior lower lid retractors. So in the Jones technique, this is now stripped and then sutured to the lower end of the tarsus. And as I had discussed earlier, a thin strip around 2 mm of the skin with underlying orbicularis oculi, which is preseptal orbicularis, is removed. This will help in maintaining the counteracting the preseptal orbicularis overriding. This is the first post-operative day picture, and this is of the second patient of Jones procedure, first post-operative day picture. Similarly, in the lateral tarsal strip with Pickard sutures, the standard technique was used with 2 lower lid everting sutures. In this picture, the inferior canthotomy and cantholysis has been done, followed by the stripping of the lateral canthal tendon, and finally attachment to the periosteum. However, 2 sutures of the Pickard sutures have been applied, one centrally and one laterally. And this is on the first post-operative day. Significant findings on each follow-up was recorded, and complications, surgical success, and recurrence of the entropion was noted. Surgical success was defined as the resolution of entropion with normal lid position after primary surgery at 18 months follow-up. Statistical methods appropriately was used and ethical clearance was obtained. Coming into the results, a total of 153 patients were included in the study with mean age of 69.86 years. And the most common age group was 65 to 79 years age group with more than 50% of the patient. Female were more predominant in our study with 1.15:1 female is to male ratio. However, the 3 study groups were similar based on the age and gender. Almost half of the patients were from Nepal and other half from the neighboring country, India. And no associated systemic comorbidities were found in majority of the patients, that is more than 76%. Thus, a total of 172 eyelids of 153 patients were included in the study, with 19 patients having surgery in both eye. And we performed Wise procedure in 79 patients, Jones procedure in 40 patients, and lateral tarsal strip with Pickard in 53 patients. The most common symptoms mentioned by the patients was foreign body sensation and watering, whereas only 15 patients complained of inward turning of flashes, which shows the general ignorance of the patient regarding entropion. The mean preoperative horizontal lid laxity of the 172 eyelids was 7.1, and horizontal lid laxity was significant in 99 eyelids, whereas it was not significant in 73 cases. Coming into the recurrence according to the surgical group, we can see that in the lateral tarsal strip with Pickard sutures, most of the patients, that is 4, had recurrence after 12 months of age group, whereas the distribution is nearly similar in Wise procedure and Jones procedure. The best surgical success rate was found in the Jones procedure, that is 90%, and it was followed by lateral tarsal strip and Pickard suture and Wise procedure. However, the success rate between the single surgeries and single versus combined surgery was not significant statistically. Coming into the recurrence based on the horizontal lid laxity, we can see that when there was significant horizontal lid laxity in the Wise procedure and Jones procedure, there is the number of the recurrences have nearly doubled or tripled in case of Jones procedure. Whereas in contrast, if there is no horizontal lid laxity, then 5 cases had recurrence compared to only 1 case in significant horizontal lid laxity in the combined surgical group. We can see that in the lateral tarsal strip group, the highest success rate was found when there was significant horizontal lid laxity of nearly more than 96%, compared to the lowest success rate when it was when the horizontal lid laxity was not significant. Similarly, we can see that single procedures have good success rate compared to the poorer success rate in when the horizontal lid laxity was not significant. The differences in the success rate, however, was not statistically significant, and the multinomial regression analysis revealed no significant association of preoperative factors with the surgical outcome, either in the 3 groups or in the combined versus single groups. So to conclude, in cases of entropion without significant horizontal lid laxity, the underlying causative mechanism would be vertical lid laxity or preseptal overriding of orbicularis. And thus, lateral tarsal strip, which just corrects the horizontal lid laxity, might not address the underlying pathology correctly. Although adding Pickard suture to lateral tarsal strip helps in preventing the preseptal overriding, but still the vertical laxity remains uncorrected. In such cases, Jones procedure corrects the vertical lead laxity, whereas White's procedure corrects preseptal overriding and some part of vertical lead laxity. Similarly, the outcomes of Jones procedure and White's procedure were better in cases of entropion without significant HLL in our study compared to those with significant HLL. This may be due to the fact that underlying horizontal lead laxity remains uncorrected with the single procedures, thus leading to recurrence. To conclude, horizontal lead laxity measurement can be helpful in deciding the type of surgery, which can be associated with the success or failure of the surgery. Single surgical procedures are equally effective in management of lower lead involved entropion compared to the combined procedure when horizontal lead laxity is not significant, that is 6 mm or less of horizontal lead laxity. However, when the horizontal lead laxity is significant, that is more than 6 mm, combined entropion surgeries are more effective compared to single procedures. A large sample randomized clinical trial incorporating the main mechanisms behind entropion with long-term follow-up is recommended to find the conclusive evidence. The limitations of this study are retrospective nature of the study, unequal number of samples in the surgical groups with no randomization, only horizontal lead laxity was considered for this study, and a recurrence of entropion in our study has been accounted as failure of the surgical procedure only. Overcorrection requiring surgical management were not considered as failure. These are my references, and I would like to acknowledge my study supervisor and group members and all the staffs of my hospital. Thank you.
Thank you, Dr. Ashish, for that interesting talk. Now we have a few more minutes for discussion. So I would like to request Dr. Professor Ukemala sir to provide a few inputs on the topic related to SHAPU and ERMD, because we don't have much time, so maybe we can take just a few points from sir.
Anyway, Priya, you do not have any questions, have you, from the audience or from the participants as yet?
We do not. Sir.
You do not. Okay. I want to comment on the first presentation of Dr. Anu Manandar, because I was involved with this condition way back from 1978. And at that time, it seems after listening to Dr. Anu Manandar, maybe there are one or two varieties of so-called SAPU or endophthalmitis. My presentation long time back, which was published in the proceedings of the first National Prevention of Blindness seminar, was titled, seasonal endophthalmitis, probably caused by tussock moths, the white moths, was the title of my publication way back in 1978. Before that, I think Dr. Upadhyay had mentioned about this condition, and he later named it as SAPU. Anyway, I want to draw the attention, there has been many studies, after 1978, mine was 78, then 1984 was Dr. Upadhyay, then 2023 was again Dr. Benjo, and again Dr. Upadhyay in 2017 and Anuj 2018. The conclusion which we have drawn, I have drawn is, until we find out the exact cause of the SAPU or endophthalmitis, we have to keep away from those white moths. The moth is called, like she pointed out, Gadalina histolofa is the name of the white moths. And I want to draw attention of Dr. Anu Manandar also and all of you, where it was the visual outcome of vitrectomy in SAPU by Dr. Benjo. I want to read out one sentence: the intense intraocular inflammation leading to rapid hypotony and Tay-Sachs lead us to the condition, probably the endophthalmitis, then uveitis or panuveitis. It's what we said, about the disease. And another one I want to read out, which I think Dr. Anu had also pointed out, is in 2017. It's a kind of meta-analysis of the SAPU. Is heading what 40 years of mystery, confusing state of affair on the cause. And he said bacteria have been reported, viruses have been detected, immune mechanism hypothesized, moths are suspected, and yet in the end, he said, no definite cause and no definite treatment. And I gathered, after listening to Anu's presentation also, the conclusion till information we have got about the disease, you all heard from Anu, she has done tremendous work on this condition. Hats off to her. And I feel strongly, whether she agrees with me or not, that the earliest treatment, I feel, is to keep away from these moths, because most of the patients, I feel, involving the children, and in my 13 cases way back in 1978, I have noticed that it's always unilateral. It's difficult to explain why unilateral. And I have noticed in those 13 cases, most of them had right eye affected. And I presume that the white moths, I've seen have nettles on their wings, like grounded glasses, and in right-handed children, they usually wipe the right eye, and maybe that's the reason why the right eye is predominantly involved. And why, and I don't know why it is unilateral. And most of my cases, they all are unilateral. I don't know. I want to hear others also. I think Purushottam also has experience. And I feel strongly, the earliest treatment within hours is vitrectomy. That's it. Maybe you can try intravitreal steroids, but number one, prevention till we know the exact cause of this condition. Number two, the earliest vitrectomy. Once you get it, you do vitrectomy within hours. If you perform vitrectomy within hours, the visual result is better. Otherwise, you lose your eye. You lose your eye within days, as a matter of fact. This is what Dr. Benjo has pointed out in his paper, which is entitled Result of Vitrectomy. So the vitrectomy has a significant role in the management of this condition, and you got to treat this patient at the earliest. And I reckon, the cases where you see predominantly, like in Gandaki and other, vitreous surgery is mandatory. I think within hours, if you can do vitrectomy, the result is better, according to Dr. Benjo. Otherwise, usually you lose the eye. In my 13 cases, I think most of them lost the eyesight, and the eye become hypotonic and soft and lose vision. But surprisingly, they all are unilateral. I want to hear what others have to say. Has anyone seen involving both the eyes, and what do they think regarding the management? This problem is coming. And the other day I was listening to radio and I was reading papers, and still, 40 to 50 cases have been reported, involving the adults also, and I think we are going to, and most of them have lost their eyesight. It's unfortunate, we have learned about this patient, way back in 1978 now today is 2021, and still we have not been able to prevent blindness, and most of them are children, which is unfortunate, as a matter of fact. That's what I want to add it. I again want to thank Dr. Anu. I want her good luck and congratulations for her studies, project research what she has done. But I think we have to come to a conclusion. We have to sit down, and I think you have done it also a long time back at B.B. Kora Line Center also, in teaching hospital. And we got to come to one conclusion. That's what I want to hear, what others have to say, and especially what Anu has to say. To me, it is not infection. It is non-infectious, suppressive intraocular inflammation or endophthalmitis, whatever. There is no role of antibiotics as far as I am concerned. But my study was, long time back. I want to hear our young doctors, what they feel about the disease. Thank you very much. Priya.
Thank you so much.
And Priya, and I want to add again about this newer drugs, which Regina mentioned, wonderful presentation. I think she updated us with all new drugs. Until now, I think in Nepal, we are using basically Avastin only. And I think some private institutions have started using Lucentis. But this newer drug, Brosus, or Pegamax also is called, is a wonderful drug, as you also pointed out. But I was listening to the experts in India. and it's good. It one injection. I was listening. If you have a retinal pigmental detachment, any wet AMD, one injection will flatten the pigmental detachment. So much so that the drying effect is damaging to the retinal pigment epithelium, and you tend to lose vision, is what I heard them say. So you got to be careful. The definite indication is the polypoidal, choroidal vasculopathy, and REPD are the one which are real indication for this drug. But I think we can start with this drug, but it is pretty expensive. You don't have to use it so frequently, I understand, but I think till now, I don't think we have started using this drug. I want to hear what others have to say about this drug, And I don't think last time I was doing my retina, I haven't done any intravitreal injection. Those days, there was no intravitreal injection for any AMD kind of thing, which she pointed out also till 2005. It started from 2005 beyond, that we started using intravitreal. Thank you very much, Priya, for giving me this time to speak out what I feel about these one or two retinal conditions. Thank you very much once again. Purushottam has anything to add? Anybody would like to add? The young doctors like yourself, Priya, and Janu also, your retinal. I want to hear the young doctors commenting on this mystery disease, what Dr. Upadhyay said, mystery disease, 40 years of mystery, confusion and all that. And we still haven't found any absolute remedy to this condition. Thank you. Over to you, Priya.
Thank you so much, sir. So with this, we come to the end of our session. So now I don't think we have much time for discussion. So I would like to request Professor Dr. Sanjay sir to provide the closing remarks for today's program. Thank you so much.
Thank you. Thank you, Priya.
Thank you very much, Dr. Priya. Diksha, I will take less than 1 minute just to conclude the session. This is a fantastic session, and all the topics are very interesting, and we could discuss for a long time, but we don't have time for that. I would like to thank the chairperson, Professor Malla. It is a privilege to have him with us. Panelists, speakers, and delegates for their great contribution in putting their talks and thoughts in the discussion to make this session great. Thank you to Dr. Srijana Adhikari, Dr. Purushottam Joshi, Dr. Priya Basgai for excellent concept brief and moderating the session. Once again, I am very thankful to the organizing team of 72nd Annual Delhi Ophthalmological Society Conference, especially to Dr. Professor Namrata and Professor Tadeya, to give us a platform to gather all of us here today. Thank you very much. Have a good night. Thank you, sir.
Thank you.
Thank you. I would like to thank all of you for doing this session. Would like to thank Dr. Malla sir because I contacted him first because I didn't know whom to contact for this because I know him for so long. So thank you so much. It was lovely seeing all of you together in all the disciplines of ophthalmology who did great presentations and lovely interacting with you. And we hope to have future collaborations on this platform and other platforms as well. Thank you so much.
Thank you, Namrata.
Wonderful.
The next platform, yes, sir. Next platform. Thank you, sir. Next platform we should be looking at is the SAG Academy of Ophthalmology, the conference of which is in December. So we'll again, I'm sure, meet there. Thank you. Thank you, Diksha.
Thank you. Very, very interesting and insightful discussions by all our speakers and fantastically moderated by Dr. Priya. A big thank you to all our chairpersons for chairing the session and to all our panelists. So before closing off with the session, I would like to take the opportunity to thank all the delegates here. And since we are a one big happy family, let's hear it for all of us out here. I would request all of you to please unmute your lines and switch on your camera. And let's give a huge round of applause for each one of us present here. Let's hear it for all of us. Great. All right. So,
Thank
ladies
you.
and gentlemen, with this, we have come to the end of day one at Delhi Ophthalmological Society Hybrid Conference for 2021. Let's hear it for the entire core team of DOS for making this conference virtually happen, considering the current pandemic times. With this is your virtual host, Diksha Raina, signing off. Hope to see you all soon again. Till then, keep smiling and stay healthy. Thank you.
Thank you.
Thank you.
Good night.
Thank you.
Thank you.
Thank you. Good night.
How are you, Rosila?
I'm good, sir.
Are you all right? You know, your voice is up to the mark.
I had laryngitis, but
Uh-huh.
kind of better today, sir. Yes, I'll
Give
be
your
able to pull out
give
today.
your voice a rest. You know. Anyway, wonderful presentation. Very much updated.
Thank you,
Thank you
sir.
very much. You know.